Good morning. Welcome back to day 3 of the 14th annual Neonatal and Pediatric ECLS Educational Conference. We're coming to you live from UPMC Children's Hospital of Pittsburgh. We have some exciting stuff planned for you guys today. We're going to start the day off with a series of fireside chats to kind of focus on some troubleshooting for the different patient populations within our ICUs. We're going to start off with our NICU. That session is going to be led by Dr. Burhan Mahmood. Dr. Mahmood was with us on the first day. He gave us a lovely talk on management of a neonatal patient on ECMO. He has joining with him today 3 of his NICU fellows. We have Darren Bodkin, Jessica O'Neill, and Anusha Chintaparthi. They are 3 of the NICU fellows that we have here that are actually taking advantage of the NICU ECMO fellowship that we offer to our NICU fellows here at UPMC Children's Hospital of Pittsburgh. It's a really great opportunity for the NICU fellows to do an intensive dive into the world of ECMO. So they have to go through the training that we put our specialists through. They have to learn to build pumps. They have to learn to prime pumps. They have to sit pump and help us with management during their intensive training. They also have to spend a week with me and follow me around and learn all the things that I do as an ECMO coordinator. So it's a really great program that we have here that was kind of brought to us by Dr. Mahmood, really seeing a need for it with NICU intensivists. So we're really lucky that we have that. Anybody looking to apply to that program, you can reach out, I'm sure, to Dr. Mahmood or the NICU people here, and we can get you information on that. Fellows, I'm sure, are always looking to do something interesting and extra. So we're going to go ahead and kick things off with Burhan and the fellows with the fireside chat with the NICU.
Okay, good morning, everybody, and welcome back. The third day of our conference. Education training is a very important part of learning about ECMO, other than taking care of patients, and our program offers those opportunities for our trainees, and our 3 fellows, senior fellows here, have immense interest in caring for babies with ECMO. So the way the fireside chat with the NICU is built, we'll have a couple of cases. We'll go through some case scenarios, give you some data, and we will ask some questions. And we do have a poll system, so we will see what kind of responses we get, and then we will explain, the rationale behind the answers and some teaching points. So we can go ahead and start. Our fellows will lead the discussion and will go over the case scenarios.
Thank you, Burhan. All right, we'll start with case 1. Ms. Smith is a 27-year-old G1 with negative serologies and negative GBS who delivers a term infant at 39 weeks. The x-ray is shown to the right. The baby has thick meconium at birth, is placed on CPAP in the delivery room for increased work of breathing and hypoxia, requiring a FiO2 of 70%. Baby Smith is admitted in the NICU for respiratory distress. Weight is 3 kilos. The initial gas shows respiratory acidosis. The baby's intubated with the 3-5 tube, then acutely requires 100% FiO2, is hypoxemic with SATs in the 70s, placed on the oscillator, requiring a mean airway pressure of 18 and amplitude of 40. X-ray is shown to the right, shows pretty diffuse opacification of the lungs. The baby's also trialed on nitric and given surfactant without much improvement, still has respiratory acidosis on the gas, and PaO2 is 35. The baby started on hydrocortisone and dopamine. And there's a question for the chat if anyone's calculating what's the oxygenation index. And I believe I got around 50 for this baby. So the baby's cannulated to VA ECMO by the CT surgery group for hypoxemic respiratory failure. These are the initial pump settings. Overall, pretty standard for neonatal babies. The flow, we typically start around 100 mils per kilo per minute to 120. And the baby's set at a sweep gas of 0.4 liters per minute. FiO2 is 35%. The pressures are within normal. And the baby's placed on rest ventilator settings. And some notable things in the first couple of hours on ECMO is a brisk urine output of 10 mils per kilo per hour. The fluid balance is negative 600 mils so far for the run, is on the typical heparin drip, morphine for sedation, Lasix infusion, and has a TPN and intralipids for about 145 mils per kilo per day. And these are some of the recent labs. Some of the notable things are the change in hematocrit from 38 to 30. The creatinine is elevated at 1.2. The anti-10A and AT3 are lower than our typical expected range that we try to achieve. INR is adequate. Hematocrit, again, it's a decrease from previous, and platelet count is also lower than the 100,000 threshold. The run has so far been uneventful. Today's day 3, ECMO day 1, and we're called to bedside for low flows, and the pump is alarming. Mean arterial pressure is also decreasing, now in the 30s. The infant's well sedated, appears pale, edematous, tachycardic on exam. You enter the room, the flows are decreasing from 300 mils per minute, which is what the baby was set on at the beginning, to less than 200 mils per minute. The venous pressure is increasing to negative 35 from negative 15. The pump continues to alarm. The baby's tachycardic at 175, hypotensive at 35/25 with a mean of 30, and hypoxemic with SATs of 80%. So this brings us to the first question. You can join Poll Everywhere through this website that you can enter on your phone or laptop. And I'll also have the QR code in the next slide. So the first question is, why could the ECMO flows be decreasing? A, high urine output from Lasix. B, due to low platelet counts. C, ECMO cannula malposition. D, clots in the venous cannula. E, A, C, and D. F, all of the above. G, A, B, and C, or H, B, C, and D. I'll give you guys a second to read through this. And there's a QR code in the corner. You can also text to 22333. That is written above your answers. So we'll give you guys a couple minutes to read through and select your answers. So far, we have E, A, C, and D, which is high urine output from Lasix, ECMO cannula malposition, or clots in the venous cannula. Any other guesses out there? Is there anything in the chat? All right, we'll go to the answers. So the answer was E, high urine output from Lasix, ECMO cannula malposition, or clots in the venous cannula. Some of the data that supports this is the brisk urine output this baby had of 10 mils per kilo per hour and the negative fluid balance of 600 despite being on ECMO for only 1 day. The increasing negative pressures also could support intravascular hypovolemia, potentially causing the ECMO cannula to be malpositioned, or the cannula malposition itself could cause high negative venous pressures. Clots in the venous cannula, again, causing some obstruction in the inflow of the VA ECMO, causing high negative pressures.
And these are all very important points. When the pump is alarming, blood pressure is going down, oxygenation is going down, you have to think on your toes. And in a baby who is having a brisk urine output, you have to address that. But then there could be something going on with the circuit or with the ECMO cannulas. So thinking through the problem is very important because time is limited.
The next question is, what will you do next? These are some of the options. A, give fluid bolus of 10 per kilo. B, turn up the ECMO RPMs. C, stop the Lasix infusion. D, change ECMO circuit. E, A, B, and D. F, all of the above. G, A and C only. H, B, C, and D. I'll give you a chance to read this. And we have an answer already. So we'll wait a minute. So far, we have G, A, and C, which is give fluid bolus and stop Lasix infusion. No other options are selected, so that is the right answer. Give fluid bolus and stops the Lasix infusion, because we are worried in this patient about intravascular hypovolemia that is causing the low blood pressures, causing the increasing negative pressures, causing obstruction in that inflow tract.
And remember, as I mentioned in my talk, volume is your best friend. So you give a fluid bolus that will correct your flows and your negative pressures, and it also gives you time to figure out, is there anything else going on?
I'll hand it over to my colleague, Darren.
Thank you. And as mentioned, the post-fluid bolus is showing improvement in the ECMO flows to 360 ml per minute, and the venous line pressures are now in the better range of -15. So a little while later, you have once again been called to the bedside due to the pump alarming. You have low ECMO flows and increasingly negative venous line pressures. Your mixed venous sats are 65%, and the patient is now tachycardic, hypotensive, and hypoxic. So we could see here there is some significant downtrending of your H&H. You're now at 9/28. When you look at that number, the anti-10A levels are 0.7, which is improved from the previous scenario and well within our range of 0.3 to 0.7. Antithrombin 3 is 95, and your PTT is 125. If you look closely, the fibrinogen number 150, again, this is above our target threshold, but the platelet count has slipped a bit. It's downward sliding. It's now 65,000. Our threshold is 100,000. So the question, what will you consider next? A, increase the Lasix infusion. B, give PRBCs at 10 ml per kilo. C, increase your heparin infusion. D, transfuse platelets and FFP. E, all of the above. F would be A, B, and D. G is B and D. Or H, B, C, and D. Let's take a few moments to review the question. Okay, so we're switching to, so we have two answers on the screen so far. So some have selected to give PRBC at 10 ml per kilo. Some have selected B and D, which is PRBC and the transfused platelets and FFP. All right, we're going to move forward. All right, so yes, correct to select given PRBC, but also you want to give platelets and FFP. You could see this patient, if you think of the data from the previous slides, the H&H has continued to downtrend, and this is a, we'll look into more in the debrief of where we'll be looking for sources of blood loss potentially in a scenario like this. But that's something that's concerning that we could acutely correct. And then you notice that the platelets continue to decrease, which is important because the patients undergoing ECMO are at increased risk of bleeding diatheses, and we want to really prevent them from having a worsening kind of outcome. So giving platelets and FFP would also, in some sense, help with volume, but it helps with the hematological type of stress that this patient is under, and you want to follow the labs acutely.
Yeah, so it's a very good point. And I think in this particular situation, with all the changes we are seeing in the hematology lab, drop in H&H and the coags being off, lowish platelet, and then the pump alarming, you definitely don't want to go up on heparin. You may actually want to cut back on the heparin along with giving the transfusions to correct these abnormalities.
Okay, sorry, I had a brief delay there. So just talking briefly about the etiology of hypotension and low flows mixed venous O2 in this scenario. Three main important points is that we should pay attention to identifying acute blood loss. Okay, so the cannula site in someone who's recently been cannulated, there's the increased risk of blood loss at that site, and just looking at that site would be an easy way to identify sources. And then, as mentioned by my colleague, the diuresis. Some patients may have such brisk response to diuretics that there's a significant increased loss. And for, not in this case, but there may be patients that you take care of who are also getting hemofiltration at the same time. That is another contributing factor, and working with the nephrology team to make sure we can balance the fluids. And so the insufficient ECMO flows is another big thing. I know our parameters are different in neonatology, but trying to target good flows to minimize increased risk for hemolysis is the fine kind of scale of balance that we're doing in these patients. So we could double check our cannula position. And a simple X-ray would be helpful at the bedside to make sure you have the cannula position identified where you want it. Worsening anemia, as we saw in this patient, is another contributing factor, and we could correct that with blood products transfusion. And a lot of our patients do get third spacing because of the loss of the protein components in their synthetic function, as well as the nutrition also being kind of put to the side during this process. So they tend to have a lot of capillary leak. And so, as mentioned before, we would encourage close watching of the suture sites, looking at your pad count with how much oozing you may see. And this is a discussion with your surgeons who are involved in the case. you want to keep them aware of any concerns so they could also review the surgical site, giving consideration to the fact your patient is on significant amounts of anticoagulation, and we have a range, right? So a range for anticoagulation, we're thinking between 0.3 to 0.7, and how you want to target that range, being on the higher end or getting towards the lower end with adjusting your heparin infusion, as Dr. Mahmood mentioned, is also helpful. Keeping your platelet count above our threshold is recommended, and of course, transfusion with PRBCs to keep our goal of greater than 30% hematocrit. And as mentioned in the first part of the case, being very, very aware of how your urine output is trending is helpful to adjust your diuretic therapy and sometimes giving more fluids, as Dr. Mahmood mentioned. Fluids is your friend, is your best friend, and you shouldn't be too afraid to give additional fluids in your patients undergoing ECMO. Now, our goals, as mentioned, for ECMO flows would be 100 to 120 ml per kilogram per minute. And again, giving enough fluids to avoid hypovolemia is important before increasing flows. And as I alluded to, hemolysis is a significant risk if you are at very high RPMs. And our venous line pressures, we target between -15 and -20 to give us a kind of a sense of where we are at in our kind of volume status, and our mixed venous sats of greater than 70 to 75% for another proxy for a patient who may need a blood transfusion. And I mentioned it before, we've got an x-ray. You could also do an echo to make sure your canal position is appropriate. You also verify that it's not unduly kinked. Looking for clots when we are at the bedside, we often are working with our perfusionists with a flashlight, looking at the cannulas to make sure we're not missing the signs of clotting formation. And we'd also talk to the surgeons if we have concerns about cannula malposition. But hydrocortisone is sometimes used not just for vasopressor support, but also helps with addressing third spacing. Now, for patients who are going to be taken off of the ECMO circuit, for whatever brief reason, you have to have your kind of contingency plans. So being aware of what would be your inotrope dosaging to be used and have on call at the bedside is important. Ventilator support, as mentioned by my colleague, your patient is on rest settings, and in this scenario, you may have to increase the ventilator support during a brief taking off of the ECMO, and be prepared for resus, because some patients, because they're not fully recovered, may not tolerate that well, and this will lead to need for a kind of a resus scenario. And whether it be you're just handbagging during that time, or even it goes full on to CPR, it's one of the things that the entire team must be prepared for. I want to hand over to you.
Thank you, Anusha and Darren. And this is a common scenario in ECMO, especially in the neonatal population: hypovolemia, high negative pressure, too much diuresis, maybe some bleeding going on. Addressing it accordingly is very important. Always remember, we use centrifugal ECMO pump. That when the negative pressures are high and the flows are low, blood pressure is low, the knee-jerk reaction is turn up the RPMs. You never want to do that. Give volume. Volume will correct your hemodynamics and will improve your preload instead of going up on the RPM, because that will just cause cavitation into the system and then lead to hemolysis, which is very detrimental to the patient. Okay, we move on to our next scenario. It's a shorter scenario, another common issue in the neonatal ECMO, and Jess is going to take over.
Yeah, thank you. So we have about 5 minutes left, so I might have to go a little quicker through this one, but we'll at least get through all the questions. So for case 2, you have baby Smith is a 2.5 kilogram late preterm infant admitted with respiratory distress and persistent pulmonary hypertension. The baby was cannulated on VA ECMO by a CT surgeon on day of life 1 for respiratory hypoxic failure. They placed a 10 French venous cannula and an 8 French arterial cannula. Prior to cannulation, the infant required dopamine and hydrocortisone for hypotension and was coagulopathic with oozing at the umbilical line sites. Once cannulated, the mean arterial pressure normalized, so the dopamine was weaned off, and the coagulopathy corrected after blood, FFP, and platelets were transfused. It's now day of life 2, ECMO day 2. You have been called to the bedside due to an abrupt decrease in pump flows, an increase in pre-oxygenator pressure. Your MAP is increasing from the 50s to greater than 90, and the infant is awake and moving. These are your initial ECMO pump settings. So when they went on day of life 1, it's all pretty standard. Their flows were about 120 mLs per kilo per minute. Our pressures looked good. Our sweep gas was 300 mLs per minute, and our pump FiO2 30%. Upon entering the patient's room, the flows are decreasing from 300 to 200 mLs per minute, and the pre-oxygenator pressures are increasing. They're much more positive, and your pump is chirping. You can see the baby is very tachycardic at 190, and their blood pressure MAP has increased to 80. They also have a decrease in their oxygen percent to 88%, and their SVO2 is low to 60. These are your ventilator settings. So there are rest settings. Just of note on this slide, you can see their urine output is pretty low, only at 1 ml per kilo per hour, and they're pretty positive for the run at 700 mLs. Their heparin is at 20. They're on a fentanyl drip at 1 and a Versed at 0.03. And then they're still on the hydrocortisone that they were on before going on to ECMO. That hasn't been stopped yet. These are their labs. I would say, quick glance, they're pretty unremarkable. Everything's pretty much in our range that we like them to be in. This is the chest x-ray. And here's our first question. So why is the pre-oxygenator pressure increasing? A, arterial cannula malposition. B, systemic hypertension. C, acute blood loss. D, hypovolemia. E, agitation related. Or the rest, a combination of the above.
Let's look at the polls.
Okay, so we have a few answers, kind of a little spread out for this one. So let's go ahead and go on and we'll talk it through. So the correct answer is arterial cannula malposition and systemic hypertension and agitation related. So what can kind of increase those pre-oxygenator pressures is anything that affects your afterload. So arterial cannula can be malposition, there can be a clot. You can have systemic hypertension related to maybe still having the dopamine on board or the hydrocortisone in this case. You could have agitation related. So remember back to this baby that said that they were awake, their heart rate was up. So this baby is getting fentanyl, and we know that fentanyl binds to the circuit more than other drugs. So it's probably related to that, and maybe we need to switch to another agent like morphine. This can happen if you were on morphine or other medications as well, and you find that the baby metabolizes it faster because of being on ECMO, so you might actually have to switch to something else a little bit sooner than normal. For the second question, what should be the next step in management? A, provide additional sedation. B, increase the ECMO pump RPM. C, assess the arterial cannula position. D, start antihypertensive therapy. E, all of the above. F, A, C, and D. G, B, C, and D. Or H, A, B, and C.
Seems like a nice consensus on this one.
Yeah, so let's see. Kind of going back to the things we had talked about in the first question, so definitely should think about providing additional sedation, getting rid of the fentanyl, maybe switching to morphine. We should check the aortocanal position, getting either a chest X-ray or an ECMO or an echo if needed, and then start antihypertensive therapy and probably definitely stop that hydrocortisone at least for now. Do I have time to go through this?
Yeah, we can go real quick. So, Jess has nicely explained the possible reasons for this issue. So, arterial canal obstruction, malposition, systemic hypertension will cause low flows because of high afterload, as she mentioned, and high pre-oxygenator pressures. And etiology is all the things that we discussed. But also remember, seizures is something that can also cause hypertension. And in a baby who's very sick, especially in a baby with hypoxic ischemic encephalopathy, these things can develop. A new seizure can develop from a bleed or a stroke or something like that. So gotta keep an open mind. Fluid overload status, this baby's urine output was only 1 per kilo per hour and was already 700 cc's positive, so that could be contributing. So multiple factors could be contributing to hypertension or could be contributing to the low flows with high pre-oxygenator pressures. We talked about all this. Minimize stimulation and making sure the baby is comfortable is important. And we talked about seizures. We get daily head ultrasounds, evaluate with an EEG. A baby who's deeply sedated may be having breakthrough seizures. So get an EEG. Neuroimaging can be done anytime. Bedside CT scan can be done because sometimes the bleed can be infratentorial and a head ultrasound may not pick it up. Neonates are at a high risk of these neurologic issues based on the pre-ECMO disease situation, and if seizures are present, they need to be treated aggressively rather than just cranking up your sedation medications. And then, as just mentioned, coming off all the meds that can potentially cause hypertension and then getting rid of the excess fluid. So having a game plan about starting diuresis or hemofiltration to start removing the fluid. You may still need to treat the high blood pressure by medications or infusions while these issues are being addressed. And then avoiding excessive flows, very important. So that's the first thing. When there's high blood pressure, look at the flows, make sure they are in the range. Remember, gentle ECMO support, 100 to 120 mLs per kilo per minute. Avoid high RPMs. All right, just two scenarios about low flows and dropping oxygenation, and but related to two different reasons, hypovolemia and agitation and hypertension. So if you have any questions, please send them to the chat. We'll be more than happy to answer. And thank you so much, Jess, Darren, and Anusha, for making it possible. Thank you, guys.
Thank you, Burhan. That was really great. Always good to have the audience participation. We really like that feature. So we're going to go ahead and switch out our panelists, and we'll move into our next fireside chat troubleshooting session. So as we do that, I'll go ahead and give quick introductions. So that session is going to be led by Dr. Nama Kim Campbell and Dr. Tim Kaslitz. Dr. Kim Campbell was one of the pediatric intensivists here at UPMC Children's Hospital of Pittsburgh. Dr. Kaslitz, as you know, you actually heard from both of them on Monday. Dr. Kaslitz splits his time between UPMC Presbyterian and UPMC Children's, where he is the unit-based education co-director of the cardiothoracic ICU at Presbyterian. So I'm going to go ahead and turn things over to them here in just a second once we get them set up with their mics and their clicker, and their slides are up here, and we'll have another interactive session. I typed in the chat how you're able to text your answers to the poll everywhere, so you don't have to scan the QR code if that's a bit too difficult. I believe it's 22333. And you text Merit A001. So that's MARIT A001. So Nama and Tim, we're going to come on over to you.
Thanks, Merit. My name is Nama Kim Campbell, and like she said, I'm a PICU intensivist here at UPMC Children's Hospital of Pittsburgh.
And I'm Tim Kaslitz, also PICU attending at Children's Hospital of Pittsburgh.
So we thought what would be useful today is to go through a couple of cases and go over a little bit of how to troubleshoot some of the patients that we have in the pediatric ICU setting. So again, this is going to be audience participation. There's a slide up here with all the information that Merritt just gave you. So if you want to take a second to log in, that would be great. Okay, so our first case, this is actually a real case. There's a 16-year-old, 60-kilogram previously healthy female who was transferred from an outside hospital to our PICU with sepsis and severe ARDS, secondary to flu A and an MSSA infection. So when she was at the outside hospital, she was intubated with etomidate and succinylcholine and was started on vasopressors for blood pressure, systolic blood pressure in the 60s. And so she was transported on an epinephrine infusion of 0.3 mics per kilo per minute and norepinephrine, oh, sorry for that typo there, infusion of 0.1 mics per kilo per minute. During transport, she had progressive hypoxia, and on arrival to the PICU, her sats were in the 80s on SIMV pressure control with pressures of 40/15 and FiO2 of 1. So the decision was made to call for ECMO. So the first question posed to the audience is, what mode and cannulation strategy should you consider? All right, do you need to activate this or something for it to? Okay. It's a free text. Okay. Oh, here we go. Okay, there we go. So it looks like most people, well, not most people, it looks like a lot of people think VA. Second is VAV, and then VV. Crescents. Cannulation. Worry? Yes, we should be worried. Okay. So, okay, so what actually happened with this patient was we planned for VV ECMO. But while she was being prepared and her neck was being prepared for the cannulas, she developed acute hypotension and progressive shock with systolic pressures in the 60s. So now she's on epinephrine infusion of 0.18 mics per kilo per minute, and norepinephrine infusion of 0.6 mics per kilo per minute. She received a hydrocortisone bolus because she got etomidate for intubation. And then she received calcium bicarb and additional crystalloid. So the plan in the moment was changed to cannulate to VA ECMO. So she ends up with a 19 French in the right femoral artery and a 23 French in the left femoral vein. She received some blood, she received some normal saline, but then her right lower extremity is poorly perfused. So what is your next step? Range cannulas. Okay. Check distal reperfusion cannula, okay, cannula position. So we'll go back one slide. So what I can tell you about this patient is that it was just the right lower extremity that was poorly perfused. So if you note, she had an arterial cannula in her right femoral artery. So this is One of the complications that you have to be aware of when a patient of yours is cannulated in a femoral artery is the distal perfusion of that limb. So the distal cannula position, or distal cannula that someone is suggesting is the correct answer. So we can talk a little bit about distal perfusion catheters. The femoral ECMO complication includes compartment syndrome and lower leg ischemia, which can lead to necrosis and the need for leg amputation. And this is because of the decreased blood supply and limb hypoperfusion just from that cannula being in the femoral artery. So distal perfusion catheters can be antegrade or retrograde, and you can really use any part of the distal arterial tree. So in this particular patient, they placed a 6 French cannula in the distal right femoral artery, and that improved her perfusion to the lower extremity. So now you're on call and walking by. This actually wasn't your patient, and you're on call, so you got signed out, you're walking by. ECMO, your FiO2 is set for 0.6, flow is at 4 liters, sweep is at 4 liters, negative pressure is a -60, and your SpO2 is in the 70s. Got to write that in. So the patient, you look at the monitor as you're walking by, and your heart rate's 150, and your blood pressure is high 90s over 70s, and your stats are 98%. So do you have any additional questions? Or do you just keep walking because you're satisfied? The SpO2 on the surface was in the 70s. Urine output is reasonable. You know, probably a little bit lower than normal, but she just went on ECMO. It's only been a couple hours. So she is making urine. Flow drug. Your flows are fine. Oh, keep walking. Why is the heart rate 150? Okay. Is there, is what? Yes, so her sedation is probably suboptimal because yes, her heart rate is 150. Yes, she's not neurologically devastated. This is a normal child, so she is aware. Okay, so that's a good question. So the question that should be asked at the bedside, what is her upper extremity sat? So you find out that the pulse ox that's reading 98% is on her right toe. So you ask for an upper extremity sat, and it's 72%. So why is that? Yep. So
Sounds like we have a pretty good consensus on this one.
yeah, that's exactly right. So she has North-South syndrome, otherwise also called Harlequin syndrome, upper body hypoxia, 2 circulation syndrome. And the reason this happens is because you have an ejecting heart. So her heart rate of 150 in a 16-year-old, obviously she's generating a lot of cardiac output on her own. And yes, it was probably related mostly to sedation, a little bit of her sepsis.
I think the other thing is that this is a fairly predictable phenomenon in a patient like this, which is why prioritizing VV ECMO in a patient with isolated respiratory failure, even if they're having some hemodynamic struggles. This is a 16-year-old, she has no prior cardiac history, and you can pretty much surmise that her hemodynamic struggles are coming from the fact that her lungs are failing. She's hypoxic, she's hypercarbic, she has high vent settings, and she's acidemic. And the minute you reverse those, her normal 16-year-old strong heart is going to kick in. So if you're really stuck in a position where you're putting a patient like this on femoral VA ECMO, you know right out of the gate that you're not done once you complete that cannulation. She's going to need something to address this problem. This differential hypoxia problem is extremely predictable in this clinical circumstance.
Yeah, and you can see that quite a bit just even at the bedside, because once someone like this is actually cannulated and gets some cardiac and respiratory support, their pressure requirements go down pretty dramatically. A lot of times they actually end up on a cardipine, or in this case, she needed a beta blocker. So the reason this happens, the Harlequin syndrome, is because you have an ejecting heart and you have fem-fem cannulation. So the arterial or the oxygenated blood is going up, essentially up the aorta and kind of competing with what's ejecting from the heart. So you have this watershed phenomenon and this mixing cloud kind of somewhere in the aorta, depending on where and how much your heart is ejecting. So in the ideal situation in fem-fem, your aortic valve's not opening and you have no mixing. So you just have oxygenated blood going all the way up the aorta into the arch. But if your heart is ejecting, depending on how much it's ejecting and how much flow you're on your ECMO circuit, your mixing cloud can be anywhere in that entire descending aorta and can cause some differential hypoxia. So what can you do about this? So in this particular case, she had a lower extremity SAP probe. Just for simplicity, you can even just put an upper extremity SAP probe on. Look for things like myocardial ischemia or neurologic changes. This is where NIRS might be helpful. And how to fix this is you can get creative and do a couple different things. One of the things you can do is actually a VAV configuration where you can put an IJ into the right atrium and you can actually do a return into that venous cannula. So then you provide oxygen-saturated blood to the upper extremity. In this particular case, they just converted her into a neck cannulation. So she had a VA conversion into her right carotid and IJ, and with a second return cannula left in place in her fem. And because of her distal perfusion on that right lower limb, her right arterial femoral cannula was removed. So that was case number 1. Case number 2.
Just to go back really quick, I think it's also a good rule of thumb that if you're on femoral VA ECMO, your SAP probe should be on the right upper extremity, or at least somewhere if you have a way to put it on the ear, or you do a no-core on the head. And then similarly, a lot of centers that do primarily peripheral femoral VA ECMO require that the arterial line is placed in the right upper extremity as well. It's just a good rule of thumb, and you can avoid not recognizing this issue when it comes up. All right. So for my case, hopefully you guys with the eagle eyes can see the dad joke right there in the patient's name. This is EC Mosavame. It's a 14-year-old healthy male admitted 5 days prior with similar symptoms actually to the primary case, or the first case, excuse me. Otherwise healthy, but obviously when they tell you that comes with caveats. In this case, it's a 14-year-old that's taken up a vaping habit and happens to be obese. So you're about to go to sleep, but they call the ECMO team just as you're about to achieve REM sleep. So here are the initial vitals there. Your heart rate's 120, your MAP's okay, but a little low. You're not on any pressors at this point. Patient seems like they're kind of in a septic state, high cardiac output. As you can see there, starting to work on a fever. Your SATs are 90, your SpO2 via right IJ. Central venous catheter is 55, and you can see your ABG. Vent settings are pretty much maxed out, so you're on 15 a PEEP and 100% FiO2. Oop. Okay. So you are consulted, you decide the patient's a good candidate for ECMO, and you have to decide the mode and then the strategy that you're going to use. Seems to be a neck and neck tie. see some people opting for a single site double lumen, some people opting for multi-site, but all in all, looks like VV is winning out. Yeah, I think that's mostly right. There's no necessarily right strategy. I think the right mode, the correct mode is VV for sure. If you opt to go in VA, you're going to have struggles similar to what we highlighted in the first case. In terms of the question of doing something like a Crescent or an Avalon versus a multi-site, the patient like this that has really sick lungs at this size, putting in a Crescent requires some fairly sophisticated imaging techniques to get right. You're probably not going to get by with a transthoracic echo to feel comfortable with that placement in terms of mitigating the risk of a cardiac perforation. You're going to require something like fluoroscopy or a TEE. So just for ease and simplicity, as well as just optimizing your support in general, I would probably opt for a femoral drain and a right IJ return, which is what we do in this patient. So we do a 25 French multi-stage drain in the leg and a 17 French arterial return in the IJ. All right, successful cannulation, but your SATs are the same. This is what the ECMO monitor looks like. You can't come down on your ventilator at all. Your PEEP's still high, your FiO2 is still 100%, so your ventilator settings are exactly the same. You can see your SAT is still 87%. It actually went down a little bit. So you can see your flows and your RPMs as well as your access and return pressures there. So it's just kind of summarizing what happens to the vitals. There we go. And then I think the next slide is the question. What's your differential diagnosis? What's your approach to hypoxia in this patient? Again, this is immediately post-cannulation. Circulation, high cardiac output. Direction ports. So a lot of good answers, kind of honing in on the recirculation point. That was probably fairly obvious to the folks that noticed the SVO2 that was actually higher than the SAT. I think having a systemic approach, or excuse me, a systematic approach of how you approach this is the important thing. So the first thing that I typically do is I check the circuit. And I think that the more you ingrain that into your head, when you have any kind of troubleshooting issue, it's really important. So checking the circuit, making sure that your membrane lung has an adequate supply of oxygen, that the oxygen supply is running, that the flows and the RPMs are adequate, are all going to be kind of the first step. And then, of course, after initial cannulation, you have the opportunity at the bedside to check your cannula position, which is what we did in this case, looking at the high SVO2 that was apparent on the monitor.
When this is going on, you often can even see it at the bedside. If you look at your drainage cannula and you see that the blood is looking better than it needs to be, or usually is, and especially in a smaller patient who's cannulated in this configuration, you can have a pretty high suspicion that you're having pretty significant recirculation.
Yeah, so those are, that's definitely the telltale sign. It's actually a relatively crude but surprisingly accurate way to look for recirculation. It's just to look for color separation in the tubing. Ideally, in a patient this size, you're looking at having your cannula about 8 centimeters apart. Other signs, like Nama said, if you have no color separation, and then it kind of becomes a little bit tricky to decide which cannula you're going to move. I would say 8 times out of 10, it's usually the drainage cannula, but not always. This is just showing you a point-of-care ultrasound image of a well-positioned cannula. You can see the tip is sitting right there at the diaphragmatic crew. just above the level of the hepatic vein. So this is sort of optimal. Sometimes when I'm placing these cannulas, I'll actually place them a little bit higher before I wean the ventilator settings, because ultimately when you wean the ventilator, the diaphragm moves up and that kind of pulls the cannula back. So if you're gonna err on one side, erring a little bit on the long side, as long as you can see the cannula, is actually appropriate when you're on high ventilator settings. And then this is showing a bicable view of the return jet, basically not entering into the right atrium at all. So in this case, it wasn't the drainage cannula, as I showed you, that was the problem. It was the return cannula that was deep. You can see in the image on the left, the two cannulas are only about 1 to 2 centimeters apart from one another. All right. This is just also pointing out the fact that if you're in a low cardiac output state or if you're near arrest, you can also recirculate quite easily. It's fairly standard in an arrest situation on VV ECMO in particular, obviously not VA ECMO, but VV ECMO, to come down in your flows to limit this down to basically 50% of what you were running before the arrest event is standard practice. All right, and then we fix the issue. Yeah, if anybody has any questions about that, we're here to chat about any. Oh, we do have a question. Yes. Yeah, so the reason why, so in a patient like this, like in my practice, we almost never lead with a crescent in an adult-sized patient with ARDS. And the reason why is we end up being flow limited with the crescent. In my talk 2 days ago, I kind of showed what some of the limitations were just with support. So if I'm anticipating somebody with really, really sick lungs, then I usually go for basically the biggest support strategy I can, and you can never do better than 2 large cannulas and two large veins. A lot of times people worry about recirculation. I think flow trumps recirculation almost every time, and with modern multi-stage cannulas, I think recirculation is largely mitigated by those. Obviously, if you're looking, if you're using it for different reasons, like a patient that you're bridging to lung transplantation or something like that, that you want to keep awake, maybe you want to extubate, maybe they're on it for primarily CO2 removal, then you can always revise your strategy to a crescent down the road. And there's more and more centers actually in pediatrics, this has sort of followed the adult practice, of trying to avoid the dreaded cardiac perforation, which happens anywhere from, depending on what literature you read, anywhere from 2 to 10% of these. So just in terms of ease of deployment, you can deploy a multi-site strategy so much more easily, quickly, and safely than doing a crescent.
It might be a little institution specific. We tend to a lot here, children's, of the crescent type cannulas, especially in the smaller patients because of the recirculation problem. So, you know, it's also a little bit more difficult to place, like Tim says, so it's a little bit the preference of whoever's cannulating.
I think the other thing is it's when they're not successful, ultimately folks tend to go then right to VA, right? So if they have difficulty placing the crescent, they'll go to VA. And I think in a patient like this, if that can be avoided, we should try to do so.
All right, thank you.
Okay, thank you guys. That was great. We're going to go ahead and switch out our panelists again. So I'll do introductions quickly while we move everybody over to the panel area. One thing to note, Dr. Sanchez is not able to be with us today because he's actually in the air flying here from Spain. So we were very fortunate that we had 3 of our other physicians from the CICU that offered very graciously at the last minute to join us on this presentation. So our session today, we're going to have Dr. Matt Bakoris, Dr. Rod Gazmezdada, Dr. Molly Lewin, and Dr. Nora Sherry. They're all going to be here with us. Matt and Rod work together to direct the Pediatric Cardiac Critical Care Medicine Fellowship Program here at UPMC Children's Hospital of Pittsburgh. Molly is one of our attendings in the CICU. Nora is one of our CICU fellows. They have a really nice session planned for you guys today with troubleshooting ECMO for a CICU patient. So as soon as we get them set up over there in the panel area, we'll get started. We don't have any poll everywhere slides, but you can type your answers into the chat again, or any questions that you have, you can please put those in the chat also. We just need a couple more minutes here to get our mics turned on and get everybody set up, and then we'll get things kicked off as soon as Devin can get back here to the camera to get us ready.
Hi, everybody. Thanks to everyone in the room, and thanks to everyone online for joining. Thanks to the conference organizers for inviting us and allowing us to sub in for a very larger-than-life human being, Dr. Sanchez-Toledo, who is mid-flight right now, but I'm sure if he could, he would have presented from the Delta flight that he's currently on. Our charge was to speak a little bit to ECMO troubleshooting for CICU patients, and again, to introduce Dr. Nora Sherry, one of our CICU fellows, Dr. Molly Lewin, one of our new CICU attendings, just graduated from CICU fellowship here, and Dr. Matt Bacoris, who's going to be our expert on the panel. Okay, so you get a patient, it's a 2-month-old with no prior symptoms, XO2 weaker with lung disease, who is showing up to an outside ER with fever, work of breathing, fatigue, rhinoenterovirus positive. I feel like it's something we're seeing a lot more in the CICU community, cardiomegaly on chest X-ray, and gets an echo, EF 15%, gets transferred to a quaternary care center, ours being the one in the local area. It gets admitted, acutely decompensates despite fluids and vasoactive, so has to go on peripheral VA ECMO through the right neck. Patient does well, gets multiple boluses of epi through the process of intubation line and ECMO to support from a medical standpoint as we go on to ECMO. And let's see what the next slide is here. Okay, so you have an X-ray that looks largely normal in terms of cannula placements, et cetera. And then you go on, the attending goes back to the call room, fellow is settling in for the night, getting the labs in order and making sure all the morning x-rays and labs are going to get sent, and they get called. Nora, you get called to say patient initially was very hypertensive. As the epi's coursing through the body, you ordered nicardipine, and we're thinking about weaning hydrocortisone, et cetera. And now they're calling you that the patient's hypotensive. So what are some things immediately as you hear that you want to work through?
Just clarifying the initial vitals, what they're actually calling you for. Oftentimes when these kids go on to ECMO, they are hypertensive with MAPS like in the 70s. So just clarifying if it's actual hypotensive or what their heart rate's doing, and then what's going on with the circuit, if it's chirping, the negative pressures, positive pressures, and then just making sure that they have volume ready to give as I'm making my way to the room.
Yeah, oh, good. And chirping might be, every program has its terminology. What do you mean by chirping?
Here, when we think about that, often it's the negative pressures are increased, so either indicating some kind of pull down episode. So
okay. So presuming you and the perfusionist have worked through the initial yeah, the patient was on a lot of epi, now probably is a little vasoplegic and working through settling in and going through the inflammatory process of going on to ECMO. You gave a little fluid, you get a little volume, you get adjusted, look at the circuit seems to be working reasonably okay, although the negative pressures are rising. You decide to call your attending to go through the second line of issues. So Dr. Lewin, what would you think about next is Dr. Sherry is calling you saying the initial round of volume is not working?
Yeah, so I think, some of what Nora said is important to think about initially, especially as you make that transition. Would expect this patient with poor ventricular function to perhaps have some pulsatility initially with going on to ECMO, and then seeing that dissipate as the epi kind of wears off, and you would expect that the circuit is providing most of the cardiac output. I think, as Dr. Sherry said, kind of looking at the circuit and seeing, are we hypotensive due to inadequate flows or kind of inadequate preload to the circuit? So the higher negative pressures suggest that the venous cannula is having trouble draining enough blood from the body to provide adequate cardiac output. And so in that case, often the answer is to give volume. Sometimes patients go on to ECMO with, they may be total body volume up, but intravascularly depleted. And obviously we're very cautious with fluid resuscitation as these patients go, pre-ECMO, because those fluid shifts can tip them kind of off the precipice. So thinking about whether more volume needs to be given. The other thing to obviously think about is your cannula position. So we had a chest x-ray immediately after cannulation that seemed to show our venous and arterial cannulas in appropriate position without any kinking in the cannulas. But it's always important with peripheral ECMO cannulation to confirm your cannula position with an echo. So that's something that we would be calling for, to have our formal echocardiogram to document the position of both the venous and the arterial cannula, as well as to kind of look for any evidence of pericardial effusion. So kind of any impediment to preload, like significant effusion causing tamponade, any kind of, we would repeat a chest x-ray to look for any evidence of pneumothorax. We would look at our tidal volumes on the ventilator and do a good physical exam for the patient to make sure that there was nothing from that perspective that may be contributing to impaired venous return, which would then lead to inadequate drainage by the venous cannula.
Dr. Bokoris, Dr. Lewin tried all these things, got an x-ray, everything looked good, tried the measures that she mentioned, and she's calling you as the senior physician at home, sleeping comfortably in bed, waking you up, and but you're happy to help her work through some more advanced troubleshooting.
Yeah, I think, echoing a lot of her assessments, I always kind of have an algorithm in my head about the approach to a hypotensive kid you put on ECMO. Like both Nora and Molly said, the first thing I think about is usually volume, and that's usually in order to see if we can flow faster. I always tell the fellows the first thing I always think about is, can we optimize flows? So usually the rate limiting step is your volume status at that point. And so I agree. Trial volume seems reasonable. And then if the child's not responsive, agree, looking for secondary causes of impedance to vascular return. So pericardial effusion, tension pneumothorax. Sometimes also, and sometimes we forget that these kids are in pretty high vent settings when they come in, and so sometimes we might have forgotten to lower the PEEP if we, if the kid was on, an exorbitant amount of PEEP when they were before they were cannulated onto ECMO. This X-ray looks like to be well expanded lungs, not too hyper expanded, so I don't think there's a PEEP issue. So short of that, then I start thinking of, if we are unable to or are at goal flows, then I start thinking of, and we don't have any big issues with effusions or pneumothoraces, then I start thinking about what we can do to augment the SVR. Was the kid on milrinone? Do we need to make that go away? Is there sedation on board left over from the procedure? Do we need to hold the sedation for a little bit? Do we need to add more vasoconstrictors to tighten up the vasculature? So tends to not be the case, especially after if this kid went on an extremis and got high dose epi. Usually these kids are pretty clamped down. So, but sometimes I like to think about the SVR afterwards too, and maybe use a little vasopressin if we need to. But yeah, that was my thoughts. I think both Nora and Molly did a great job.
Yeah, sometimes the professional opinion is just, keep it,
do more
keep it up and keep going. So they did get an X-ray. After the morning X-ray, they gave some, there was some brief period where there was agitation and some lifting when the patient moved and kind of got up, and the problems seemed to be exacerbated after that. Do you guys, you get this X-ray, Dr. Sherry, what's your first thought?
Sorry. Yeah. So just taking a quick look at this chest X-ray, you can see that your arterial cannula has definitely moved with the agitation. You can see it's quite deep, and now probably rather than looks like it probably courses down your descending aorta right like at where the aorta comes up. So I would like to then probably call our surgeons in.
Yeah, exactly. And we have a few different pictures here of different cannula positions. Obviously, as Dr. Sherry mentioned, the arterial tip is a little too distal here. There may be situations also where your arterial cannula might be kinked or turned depending on how it's secured to the neck. This would present itself differently from a venous issue in the sense that your positive pressures are increasing. So you have to differentiate between high SVR state and are you not flowing enough because of that, or because there's actually a mechanical issue with the cannula. As we can see here, this is a situation where the venous tip has moved and is now too proximal, and this would present as more worsening in the negative pressure on the venous side. So you would have to differentiate between volume or any of the reasons that we said about impaired venous return, like pericardial effusion, et cetera. This is an example of a venous cannula kink. And clearly there is something that went horribly wrong here because the venous cannula has now descended its way into the abdomen, and Dr. Sanchez Toledo's love for ultrasound is demonstrated here as he shows the venous cannula well into the abdominal ultrasound. Okay. So you made it through that journey, but now in our night float system, you survive one night, you got to be back the next night to deal with what may come. So nurse calls you to the bedside again because of frank blood coming from the ET tube. So what are your thoughts on what happened here?
Yeah, anytime blood is coming up from the endo tube, the first thing we do is get an X-ray. And with this X-ray, you see kind of diffuse whiteout of the lungs, whereas when we went on, our lungs were clear. And now with the new, what sounds like pulmonary hemorrhage, I would be concerned that although your venous cannula is draining appropriately, that there's now increased pressure and your LV is not appropriately decompressed. I was like, thank you. So that would be my concern. That so then at this point would probably want to either get an echo or go to the cath lab to appropriately decompress with a BAS.
Dr. Lewin, as Nora's calling you with that recommendation, what is how do you differentiate between when you need to go to the cath lab for decompression, or is this a complication related to separately to why they came into you? So they presented in myocarditis, heart failure-like picture, but also is in rhinoantero, and this lung could be complete whiteout from viral syndrome. How do you differentiate, and what is the priority to deal with?
Yeah, so I think, one of the ways that we can try to tease that apart, as we know, pulmonary hemorrhage can be a complication of ECMO in general, with anticoagulation and sometimes sick lungs, especially in the setting of an active infection. But I think in this case, this is actually, given the history, a patient that I would expect more likely than not to develop this problem in the setting of being on ECMO. I think an echo can be helpful for us to differentiate. Seeing a very significantly dilated LV that is kind of truly filled, and sometimes we can actually see thrombus in the LV in this context. As we know, kind of with significant LV failure and kind of a dilated LV that doesn't squeeze well at baseline, ECMO can actually worsen the loading conditions of that ventricle, as you still have some degree of native flow through the heart, even though you're trying to offload as much as possible. And then you've actually increased the afterload on that very sick left ventricle by putting, the arterial cannula with then retrograde flow. So you've actually made it even harder to offload this very sick left ventricle. So oftentimes echo can help you to see that. You would also see a significantly dilated hypertensive left atrium, and it's kind of the backflow of pressure from that LV to the LA with LA hypertension that then backs up into the lungs and causes pulmonary hemorrhage. So we should be able to see evidence of that on echocardiogram, and that would be one of the first things, as we were notifying our surgical and cath lab colleagues about the likely need for decompression. We would be getting an echo to document that. Some of the other things we can talk a little bit more about, kind of general pulmonary hemorrhage management on ECMO, but I think for this particular patient, for all of those reasons, I would be highly suspicious.
Yeah, I think everything you said. So echo, I think, will be a good guide. If echo's not, if it's the middle of the night kind of situation, kind of also, I think the clinical picture and the timing of the x-ray. So if you had a clear x-ray, you put the kid on ECMO and there's whiteout, I mean, that's usually not like a viral process that is burgeoning. It's usually mechanical. LV afterload is severely, acutely increased when you put the kid on ECMO. So a lot of times the timing of what the serial x-rays look like can guide you to what's the underlying kind of pathophysiology that you're dealing with. So I agree. I think with the timing of, a near clear x-ray, it's less likely to be pneumonic effusions from viral process and more likely to be you're dealing with some LA hypertension with need to decompress the left side of the heart. So whether or not that's going to be a cath intervention with the sternotomy wires, I assume this patient is post-op, so sometimes also consider actually putting a vent directly into the heart. So that will be, a discussion to have between cardiology and the CT surgeons. But yeah, I think echo will guide you, as well as kind of the general course of the patient.
Hello. Okay. So someone needs to troubleshoot this mic. We have, in the cardiac ICU, also actually used, obviously for this patient that's a young infant, it wouldn't be an option, but for some of our older patients, adult congenital single ventricle Fontans, if we don't think they are already have an open atrial septum, or we think they're too unstable to move forward with an open atrial septum, or even if we do that, that might not be enough to unload. We've used some other strategies with mechanical support in addition to ECMO to help offload the single ventricle or LV. Can you speak to that a little bit, Dr. Lewin?
I mean, I think what you're referring to is that for some of our adult patients, we'll sometimes fit for an Impella to kind of help to support and offload the LV as kind of a more durable support than just opening the atrial septum.
Just some of the slides reiterating some of the things that were already mentioned. So evaluating your pump pressures, looking for reasons the circuit itself might fail, or the symptoms of cutting out or chirping. That's managed with volume, position change, managing patient activity, and evaluating for other complications associated with ECMO, bleeding, pneumothorax, and pericardial effusion, et cetera. And we go through some of those things that we mentioned just to prompt us if we need to. Again, some more pictures of patient cannula malpositions and pulmonary hemorrhage related to LV unloading issues. So one of the things that we forget about just sort of in the last minutes of the session is, you get very focused in on running the ECMO circuit, forgetting that at some point ECMO is going to become more trouble than it's worth. So I know in the cardiac ICU, we always focus on, as soon as we get on, what's our strategy to get off? So what are some things that we ensure or help manage to ensure a successful exit off of ECMO, either to recovery or other mechanical support?
So, I think one of the things that we want to make sure that we've optimized every other organ system, and because as Rod was saying, every day that we're still on ECMO is a day we should be asking why we're still on and how we can get off. So I think, one thing is monitoring for myocardial recovery, if you think that's something that is feasible, and if not, then planning for a transition to something that's purely cardiac support, like a VAD. So you want to make sure from a cardiac standpoint that you have controlled any arrhythmia. So, we aggressively treat arrhythmia even on ECMO. It can interfere with flows in general, but even so, it will interfere with your ability to come off. So we want to make sure that we have kind of good sinus rhythm with good AV synchrony, and that we're not having frequent arrhythmias is one of the things we want to ensure. We, from a cardiac standpoint, would also want to make sure that the cardiac function is adequate as, on clamp trials, as we wean flows and ideally temporarily cease flows, that you can support, can generate enough of a blood pressure on reasonable amounts of inotropic support in order to kind of support end organ function as you come off. You also want to make sure you've addressed any, for this particular patient, this was not a patient with kind of underlying structural heart disease from a surgical standpoint, but you want to make sure you address any residual lesions that need to be repaired prior to the patient coming off of ECMO. And then, as I said, you want to make sure you've optimized all of your other organs. So you want to make sure that your lungs are, healthy enough, well expanded. We utilize rest settings, as Matt was saying, as a way to kind of streamline our ECMO management, but you want to make sure the lungs are well recruited. You don't have significant effusions, atelectasis, pneumonia, anything like that, and want to make sure that your lungs can do their job as you come off ECMO. And then the other thing is you want to make sure your volume status is adequate, that your kidney function is adequate. We're pretty aggressive in our institution about using adjunctive extracorporeal therapies. When you can, it's best to use the native kidney function. So if the patient can tolerate being on diuretics and can kind of void well that way, that's obviously best, but we're pretty quick to use CRRT or hemofiltration to help with volume removal to optimize volume status and make sure that that's kind of a good spot to come off. I think those are kind of some of the big things that I think about in readiness and optimizing for potential decannulation.
Dr. Prochorus, in our field, neurodevelopment and neurobehavioral issues are becoming more and more on the forefront of things. How do you ensure in your practice that the brain is healthy at the end of all this? How do you maximize the support of that?
Yeah, so I think we're pretty aggressive here in Pittsburgh and kind of neuroimaging. So, usually our kids will receive daily head ultrasounds if their age allows a head ultrasound to occur. Certainly, I think we employ, much to the chagrin of our neurology colleagues, continuous EEG monitoring. I remember a study, I can't remember the year, I think it was in the early 2010s, where CHOP did a study where they basically hooked up every ECMO kid in the whole hospital on EEG and ran it for their entire ECMO course. And the incidence of like non-clinical status was like 25%. So it was not a small number. And I think that's pretty much standard of care here is, continuous EEG during the entire time the kid's on ECMO. Older kids, I would say, or adults, you're limited in the head ultrasound department, but we're lucky enough to have a portable CT scan. So frequently we will at least do a baseline scan during the ECMO run, bring the CT scan to the patient. We also utilize NIRS a lot. I kind of think my use of NIRS is kind of the absolute number probably doesn't mean as much, but I think it gives you a good trend of when something is going amiss, if there's a big delta and what your baseline NIRS number is doing. So I think a combination of all those things kind of allows to have pretty good neurological outcomes in our patients.
Great. I think that's getting close to the end of our session time. I'm happy to answer any questions that either appeared in-house or online for the panel.
I think, like we mentioned before, acute LV distension after going on ECMO is likely related to just sequela of going on to VA ECMO, given that we know that when you place an arterial cannula in the carotid artery, it's going to acutely increase the LV afterload, usually in a heart that's already not doing well for whatever reason, either post-op or some myocarditis or cardiomyopathy. So I think it's an expected sequela or complication. I think everyone in the CICU is usually acutely aware of that complication and is usually actively looking. Once you go on ECMO, we get an echo to see is the LV decompressed, because that's usually the goal, is to give the heart rest. And if you're not fully resting the heart, you need to do strategies in order to do that. So in our institution, I think that if it's not a post-op surgical patient, likely the first step would be a catheterization to perform a blue atrial septostomy. The more gray areas, if it's a post-op patient, sometimes it's just easier to put directly an LV vent in, but that will usually be a discussion between us and the surgeons.
And oftentimes, once you take the LV out of the picture, then the RV decides that it's the next best troublemaker and needs a little attention as well. I think that's all our time.
Okay, great. Thank you guys so much. We're going to take a quick pause. We have a couple of our panelists joining us on Zoom. And while we get our panelists that are here in person into position, we'll take a quick break and then we'll be right back with our next panel discussion, which is going to be very interesting. It's on anticoagulation. Can you handle the truth? So it's going to be an internal look at our center experience with BiVal for pediatric ECMO patients. So it should be an interesting discussion. Stay tuned and we'll be back in about 2 minutes. Okay, welcome back, everybody. We're really excited about this next panel discussion. Anticoagulation, can you handle the truth? So we decided we were going to kind of take a look at what we do here with bivalve for our pediatric ECMO patients. We sent our current guidelines for the PICU and the CICU out to the panelists that we have here. So I want to welcome Dr. Heidi Dalton, who is the Medical Director for Adult and Pediatric ECLS at Inova Fairfax Medical Campus and Inova Children's Hospital. Dr. Ravi Thiagarajan, who is a Professor of Pediatrics at the Harvard Medical School and Chief of the Division of Cardiovascular Critical Care. Dr. Federico Xavier, who is an Associate Professor of Pediatrics at the University of Pittsburgh School of Medicine, Associate Clinical Director of Hemophilia of Western Pennsylvania, and is here with us at UPMC Children's Hospital of Pittsburgh. And Dr. Tim Caselitz, who you guys have seen throughout the conference. Again, he is one of the pediatric intensivists here at Children's Hospital of Pittsburgh, and he also works as a critical care intensivist at the University of Pittsburgh Presbyterian, where they also have experience with bivalve with their ECMO patients. We're going to moderate this session by myself, Merritt Aspenleiter, who's the ECMO coordinator here at Children's, and Holly Hollenbaugh-Fogel, who is one of our ECMO specialists here at Children's, who is very interested in anticoagulation and is always helping us to look for ways to improve the care that we give to our patients. So I have a few slides that I'm going to run through really quickly, and then we're going to open it up to the panel and see what kind of feedback we can get on what we have here so far. So I'm not going to, in the interest of time, read through the anticoagulation guidelines for bivalve for both of our units, but they have been sent out to the panelists and they've had a chance to review those guidelines. So they are here and they will be sent out to the conference goers as well. So we'll flip through those. And then the things that we're really looking to see is we have limited experience with bivalve in our ECMO patients, so we have some perceived potential challenges. So the potential challenges that we're thinking we might encounter are going to be increased incidence of circuit clots, increased circuit changes. Anecdotally, we've recently had a group of complex long-term patients, so some BIVAD kids who also spent some time on ECMO, back and forth ECMO to BIVAD, and several different ECLS configurations, a central ECMO cannulation that was long-term while awaiting a lung transplant, and both patients had heparin and bivalve used throughout their ECMO runs with some challenges. The things that we're seeing don't seem to be statistically significant because it's only been a few patients, but we want to kind of get ahead of things rather than be behind when we do start using bivalve a bit more frequently. So the questions that we're hoping to have answered are here. So we're also wondering if there are centers that are out there that are having success with bivalve, and what are they doing to achieve this success? The next question is, what, if any, challenges did they see or do they see when they're using bivalve in the pediatric population for ECMO anticoagulation? We also want to know if they've made any changes or adjustments to their practice related to their ECMO circuits while they're using bivalve. Are there any patient factors that you'd steer away from when you're using bivalve? What are your thoughts on heparin versus bivalve, and do you feel strongly one way or another, and why? So if we want to go ahead and start off with that, first question about, we're wondering if there is success out there with BiVal, and what are these places doing to achieve success?
Okay, I guess I'll start. I'm Heidi Dalton. Thank you for inviting me. Yes, there are many centers out there that are
Dr.
using
Dalton,
BiVal.
one moment, please. We're not hearing your audio. I apologize.
Oh. Can you hear me now? Can you hear me now? Yes, you can hear me. Okay, great. So I would say that there are many centers out there that are successfully using bivalirudin. For instance, the Mayo Clinic has used bivalirudin exclusively, I'd say, for the last 5 years in all of their patients. And they've published some on
They
that
can
as
hear it
well.
online? Okay, we can't hear it in the auditorium here, Dr. Dalton, so if you could just bear with us for just a minute.
Sure.
While we're waiting to get the audio sorted out, Tim, I'm going to go ahead and ask you, I know that over at Presby, BiVal is used routinely or almost always on your ECMO patients over there. Is that correct?
Yeah, that's right. We made the switch from kind of a heparin BiVal, based on clinical preference before 2020 to around, when the pandemic started, to go into bivalirudin exclusively. This was for multiple reasons. One was to sort of simplify the agent that we used. Some of it was based on some observational data that had come out of some large volume ECMO centers, including a paper from our own. Rivasecki et al. Published this in 2021, improved clotting outcomes, as well as, I think maybe some improved circuit clotting outcomes, as well as bleeding less blood products over time. So we made that switch, like I said, in 2020. There's a lot of caveats that obviously come with taking care of adults on ECMO that don't quite apply in the same way as pediatrics. For one, the highest risk for HIT is in adult cardiac surgery patients undergoing cardiopulmonary bypass. So to basically obviate the need for worrying about that, we made the decision as a group to go to bivalirudin exclusively.
Thank you. We think we may have the audio figured out. Dr. Dalton, if you could give it a try for us.
Okay, can you hear me now?
Oh, great. Yes, thank you. Welcome.
Thanks for inviting me. I was just going to follow up that, yes, there are many centers out there that are using BiVal very successfully. The Mayo Clinic has been doing it for over 5 years in all their patients. At ANOVA, where I do actually mainly research now, we use BiVal and heparin sort of interchangeably. And we were using BiVal all the time. Then we have some new people, went back to heparin. It's back and forth and that kind of thing. I think a lot of it turns out to just be what you decide to do. If you skip ahead to all these questions, there is no data that shows exclusively that one is better than the other. All the BiVal stuff is retrospective. It's done from meta-analyses of different studies that use different equipment and different levels of monitoring and all that stuff. So is there one better than the other? I would say absolutely not. And one of the things that I'm trying to put together right now, and actually, maybe Pittsburgh is too far along to want to do this, but at least in the adult world where I spend a lot of my time now, we are interested in doing an actual BiVal and heparin randomized study and trying to standardize as much of the care as we can get in terms of like transfusion triggers and stuff to take out some of their variability. And if you guys are interested in that, please let me know, because I'm trying to put that together into like a U or an R or something like that towards the beginning of next of next year. And we use it in peds as well as adults. We do, if you're going to be really slow or clamping, we do use heparin and switch off the bivalve at that particular time. And actually, I saw a new article like this week or last week or something about the potential for bivalve actually preventing some of the PF4 activation that people think is related to HIT when people get heparin. And so this is a rat study, but looking at the fact that by giving these animals bivalve, it reduced the activation of PF4, and maybe that will reduce the incidence of HIT in patients that end up getting heparin later on, because obviously bypass patients still get heparin. But anyway, those would be my quick comments.
In your patients that you switch from bivalve to heparin when you're doing a clamping trial or a low flow state, is that for the clamping trial, is that a quick bolus of heparin, or you switch to a drip?
It depends. It depends. Sometimes we just give a bolus if we think it's going to be short-lived. If we think that the patient is going to be not weaned off right away or whatever, sometimes we'll just switch them back to heparin. And I will say, even if we start with heparin, the minute that we start either escalating doses or people start talking about checking antithrombin levels and all that stuff, we just switch them to bivalve. And I think one of the reasons why the blood product use with bivalve may be less is because people suck less blood out of patients doing testing, which is probably unnecessary. I don't know why we monitor heparin so much, actually, but I think that is one of the reasons. And certainly during COVID, we used bivalve a lot actually during COVID, just, I don't know, because of preference, and we didn't want to break into the circuits or go in the room very much or anything. So we didn't monitor it more than, once or twice a day in terms of how you monitor it. And nobody really knows how to monitor it either. We use the APTT. There's some data again from Mayo. They have a actual way that you can measure bivalve levels in the blood, and so we're working with them to see if we can come up with a score, a scale, or something that would relate bivalve dosage to either eccrine clotting time, if that's what we use, or the loop thrombin time, or APTT, or whatever. And when any of those things turn out to be accurate, which one is best, I don't really know. But I think by the time we know the answer to this, we'll be on to a different drug, probably.
Thank you. Dr. Thiagarajan, do you have any comments for us?
Yeah, just to support Dr. Dalton's comments, the practice is very variable across pediatric centers. We certainly use a combination of heparin and bivalverin. I would say that if you came to the cardiac intensive care unit, most patients are, I would say all patients on ECMO are anticoagulated with heparin. There's a small group of neonates that the pediatric intensive care unit is using bivalverin on. They're required to move from roller pumps to centrifugal pumps to be able to effectively use bivalverin because the risk of thrombus, especially in a circuit with a large number of connectors, is quite high if you use bivalverin. So I think the fewer connectors and the fewer areas of stasis, bivalverin requires that type of circuit arrangements. So yeah, a combination.
Thank you. Dr. Xavier, what are your thoughts on bivalve versus heparin?
Yeah, so I agree pretty much with everything that has been said. I think that bivalve, the advantage is because everybody's saying it's easier, right? Because the heparin depends on antithrombin to work and has this erratic behavior, binding to all kinds of proteins, and clearance can be different. But yeah, the main point is which drug is better in terms of monitoring, right? Because which one to choose. And then we don't know. There's nothing that, as everybody pointed out as well, in terms of monitoring hematology, we just like try to help you guys, but there's nothing much out there that can precisely monitor any of those. But however, I'm from elsewhere. I'm not American. So then one of the things that we have to always consider is the price, right? The heparin is way easier and way cheaper in terms of management. And then also in pediatrics, right, we have the developmental factors and falling liver. So those things as well, because we always try to adjust the patient to a guideline that is most often coming from adult. So we have to remember that especially in neonates, it's a completely different animal, right? That we are transforming that little baby in adult to monitor and dosing and etc. And I do agree, maybe in the future we're going to have a better medication to use, right? And people are exploring anti-12 nowadays, right? Seems promising. We had one case here that I would love to try a few things, but of course this is not only a case of one, that we had a patient with congenital severe factor 12 deficiency that went on ECMO, and then none of the labs worked because of the 12 deficiency, and then the kid was managed with the regular doses of heparin and did relatively well. So yeah, so the $1 million question is which drug is better? I have no idea, but the easier one is Bival, but the price may be a concern for different countries out there. And then I do think that labs are a real problem, and identifying your patient and the deficiencies and age that may require different sets of labs to be paying attention to. And I think that, we need a new drug or new labs because we are not there yet.
So if I can just interject, I am also doing work with factor 11 and factor 12, actually. And what I'm doing right now is there really isn't good baseline data for what those levels are in patients on ECMO. So I have about probably about 70 patients now that we're analyzing those results on, and I'm working with a small company that makes blockers to that parameter as well. And I agree, the data is really, it's still new, but logically, it seems to make sense. It blocks contact activation. So, if it were to work and you could give a bolus of this or a shot of this stuff before you cannulated patients, and you didn't have to give it, because depending on the dose, it can last for a couple of weeks even. Maybe that is really an answer, and I'm hoping that will help. But in talking to people that know more about that than I do, it seems like you really have to knock the levels of that down to almost zero for it to not have its just block thrombogenesis. So I'm just getting baseline levels over time to see what they are on ECMO. And then hopefully from that, we can develop a study where if we gave blockers, we would know what kind of dose we would have to give.
And also in terms of news, right, that there are a few folks studying a new assay as well, bedside, that is almost like a tag or a Rogan using APTT base that looks promising as well in the few cases that they published. So we are hopefully having more to add to the labs as well.
So I just had a quick question, probably for Dr. Xavier. So when you start bivalve, it's easier to achieve a therapeutic value, which we all kind of know. Heparin, when we start upping and increasing doses, and then we reach the level where we think that they need to switch to bivalve. That usually happens early on in our ECMO runs, and it happens pretty quickly. But we later on will end up with bivalve resistance. And so it seems that when we have the titration, the uptake of titration and heparin, that we're very concerned about, that happens really early, and then we switch to bivalve and we become therapeutic very quickly, but it doesn't level out for like the rest of the run. They develop bivalve resistance, and it ends up that we end up titrating bivalve almost just as much as we've titrated heparin. It's just later on in the run. And we also don't seem to be super concerned about how high our bivalve doses are. Can you answer that question for me?
Well, I think that's it's because of the lack of good labs, right? So then that's why the definition of resistant to Bival, I don't know if anyone knows.
That's right. That's right.
Right. So then I don't know that I had a professor used to say, well, if you don't seek a lot, it is working, right? Because some folks doing diluted thrombin time that unfortunately we still not there yet, but that's what we need. We need a better assay to see if it's working or not, because saying that there is a resistance only based on labs, I don't think that we can actually say that yet. And then, as I said, that if you're not having clotting issues, I think that it's working. Keep the ship sailing and pray for the best. There are some centers, I think, that once they achieve the level, they don't even monitor anymore because
That's right.
because of the
Yeah, I think we hurt ourselves by monitoring too much.
right.
You know, and everybody worries about flow rates and clotting. I can tell you, I just gave a talk at ELSO about this. There is not one study out there that actually says at X flow rate, your risk of clotting is Y. So I'm not even sure that there are some centers that say, if you're an adult, especially, and you're going over 3 liters a minute or something like that, don't use anything, and I'm not so sure that that isn't a bad precedent. I think a lot of this anticoagulation stuff is made much more complicated by ourselves than it is by anything else. Oh, there was also a good talk at ELSO about the cost, actually, which turned out to be favorable. Even though the drug itself costs more, if you don't monitor as much and you don't give as much blood products, it turned out it was a favorable cost analysis as presented there.
I think that's such a good point, and that's actually where my clinical practice has largely moved towards. We have a fairly simple protocol in our adult cardiothoracic ICU that basically lends itself to, once you're kind of in the ballpark, I look at the APTT once a day. Generally don't find that we're titrating a lot. And also, as you stated, for VV ECMO in particular, we have a lot of patients now, because of modern technology with the circuits and the cannulas and everything else, that have some contraindication to anticoagulation, and I'm shocked by how long we can keep them off of anticoagulation before we run into any issues at all. Again, a little bit different adults that you're able to flow 3.5, 4, 5, 6 liters as opposed to a neonate or a young child, but nevertheless, it's been eye-opening to me just to see how few issues we have.
So
I'd love it if we could put those numbers together, because I have a DoD grant that's interested in that. And a lot of us have periods of anticoagulation where we don't give any, but it's hard to record it. But if we could put together a cadre of patients and say, in 50 patients or something, we ran no anticoagulation for X number of days or hours or something, I think that's a good basis for a grant, actually.
Our record in a COVID survivor was 5 weeks without anticoagulation. She had hemorrhagia that just wouldn't go away, and she was on 5 weeks, and ultimately was accumulated.
Awesome.
With no circuit change. We do have a quick question that has come in through the chat. Why do we use PTT to monitor bivalve and anti-10A for heparin? They really don't measure the same thing. 10A is more like a heparin level, and PTT corresponds more to status of coagulation system. Is there anybody on the panel that would care to address that for us?
As it is so that's what I'm saying, that if people ask me to pick one assay, I say I can't, because especially in right, that we are in the developmental phase of the liver and maturation and everything. I think it's extremely important to have an idea what's happening on your background as well. So then, yes, I do agree the anti-10 it was designed for heparin, low molecular weight management, but most, not unfrequent of it, we have several papers showing that they don't relate to the PTT, right? So then I think that we do have to always look on both and see what's happening, or like the panel was saying here, or even forget about monitoring at all and just flow with what we've been doing. Because it is hard to choose one assay when we don't have a good assay at all. So then, yes, the PTT maybe is better for the background to monitoring, but it's still a good initial test for BVAL as well. And then we don't have a perfect assay for either. So that's why I think that, yes, when you're like in the beginning phases of when you're trying to achieve ventriculation, it's good to have an idea what everything is happening. But once you get there and you're not seeing clots, or depending on the rate you are, then just calm down and the ship is sailing, and try to reduce the amount of stress adding to labs that you've been doing.
We
The
also
other thing,
see in the
sorry.
chat, what about TEG or ROTEM? What is your view on these tests to titrate your clotting status?
So I was just going to say, I tend to use that a little bit more than I used to. And actually, I'm doing research now and playing with a point of care VCM TEG device that uses 3 drops of whole blood at the bedside. And I think that'll be on the market, actually, just as a transparent thing by the end of the year. And I really think that's helpful. We do have data on bivalve and heparin patients with that to show that it does prolong your clotting time. But I like that because it also gives you some information about your platelet function, a little bit about, you know, your clot breakdown and that type of thing. And except for the fact, you know, I think both, and Ravi, you can sleep in here too, but the problem with TEG and ROTEM both is they require a fair bit of manipulation, I guess I would say, you know, and you can't do it right away at the bedside. Even, you know, the TEG 6S, which they tell you is point of care and all that stuff, it's really not. And the R time cuts off after 12 minutes, which I would like to know if my R time is 30 minutes versus 12 or whatever. But I think there are some new devices coming down the pike that give us more of an example of the entire clotting picture. You know, I don't tend to use the ACT anymore. You know, we get all these labs, but I agree that if your patient isn't clotting and he's not bleeding, then stop doing things and just leave him alone.
Yeah.
I think the important thing about
I like
testing
because in PEDS, right, that one of the things that we don't think much is about the acquired von Willebrand that can happen with the shooting forces, and then that's the patient that keeps oozing and you have no idea why he's oozing. So I like the tag or because that's the assay that you can use to see what your fibrinolysis rate and to help. But as I say, it's hard. It's case by case which lab you're going to be looking at. It is hard to choose one lab. That's I think that the message is, and as everybody agreeing to, try to do the lab like for specific questions and specific scenarios once you are on a failing mode, autopilot, because yeah, adding much information sometimes can be detrimental. And in PEDS again, right, the amount of blood you're requiring to do all those labs, I don't think it's going to add much to your clinical management at the end of the day.
Dr. Thiagarajan, you had something you wanted to add also.
Yeah, what I wanted to add is that the way we've thought about anticoagulation is that anticoagulation not only comes from the agents that you're used to anticoagulating, but there are patient factors that lead to either turning on your coagulation system or consumption and therefore an anticoagulated state. And you don't want to give them more anticoagulants if they already have baseline coagulation abnormalities. And the whole blood coagulation test kind of help you kind of have a general idea as to where a patient is in the spectrum of being anticoagulated. And therefore, we think that that's useful. We do thromboelastography as part of our anticoagulation protocol, but we don't use it to titrate our anticoagulants, but rather understand background coagulation activity in our patients. So we use TEG maximum amplitude to kind of set the day for anticoagulation for our patients. So if your MA is really low, and we use a cutoff of 55, and that's derived from cardiopulmonary bypass patients, then we choose a relatively conservative anticoagulation strategy for the day. And if in the next day your MAs are higher than 55, then we would go back to our regular anticoagulation protocol. But saying that, I would say that the majority of, all of my patients are patients who've had heart surgery, and therefore they're at breathing risk to start with. And our protocol is designed to really prevent risk of bleeding in our patient population. So I think it depends on patients, type of patients you're managing, whether they're at risk for bleeding, and their underlying coagulation system. So it's cannot be, I think, encompassed in one test, but perhaps an understanding of your patient and their coagulation system.
Thank you. One other question we've had come in the chat is, has everyone moved away from ACTs regardless of heparin or bivalve? I can't speak for everyone, but I can say here at Children's, we run ACTs early on in our ECMO runs. Really, we just want to make sure our heparin is in and circulating and that it's actually working. So maybe a couple ACTs for a patient, and then we don't do ACTs after that. I'm not sure what they're doing over at Presby, or if Ravi and Heidi, you could weigh in on what you guys are seeing.
Yeah,
So we use ACTs only when we start and give a bolus, just like you said. And in the OR, they use it, to make sure the patient is anticoagulated. But truthfully, I think this little viscoelastic device at the bedside is going to kind of replace that too, because you're going to be able to see right away if your R time is prolonged.
We don't use ACTs. We've moved away from it, mostly related to technology and what it measures, and so.
Just in the OR, we don't use it in ECMO.
Thank you. So now that you guys have had a chance to look at our guidelines specific to the sections on bivalve, do you have any comments, advice? Is there anything that stood out as maybe needing some adjustments or twerking, or do you think it looks, how do you think it looks?
Well, with the caveat that you're using PTT, which we all agree isn't a great test either, I don't know what else to add about that. I am working with the folks at Mayo about doing a comparison between this eccrine clotting time, a bivalve level that they have developed, and PTT data that I already have, to see how much they associate or not. I will tell you that this little coagulation device I mentioned did seem to have a better correlation between the clotting time and the APTT than did the TEG 5000, which is what we use clinically at ANOVA. And I don't know whether that's good, bad, or indifferent, but it looks nice on paper. Again, I'm not sure any of this stuff matters in terms of our patients, but I do think it's good to have a protocol, at least for people to follow in some way. And certainly at Ravi's place, they've done a nice job with analyzing a lot of their anticoagulant data. And do you guys still use the R time and the MA, or are you just using something else, Ravi?
We just use PTTs now for our anticoagulation protocol, and it's kind of a common across both heparin and bivalverin. The one thing that, just to answer the question, I think your protocol is very detailed. It looks really, really excellent. The one thing that we have noticed, we don't call, no change in PTT despite increasing a dose of bivalverin as bivalverin resistance. We call it ceiling effect. And once you reach the ceiling effect, then we would use prothrombin time, or PT, to ensure that a patient is adequately anticoagulated. So for patients whose PTT is not changing, then we'll ensure that the PT is 2, to kind of say that your patient's adequately anticoagulated in patients who are using bivalverin.
Do you use diluted thrombin time at all, or no? No?
No. I think the issues may be the same with dilute thrombin time as well.
Okay, thank you. Are there any questions from any of the attendees we have in the auditorium here? No, so it doesn't appear that there are any more questions. Do you, Dr. Dalton or Dr. Thiagarajan, do you have any closing comments for us? I know that's a trick question.
Yeah, well, I think it's a really important area for further research. Certainly, our programs, ECMO programs across the country and across the world differ by their coagulation strategy, and it may be rooted in the type of devices they're using. And I think in the future really is going to be trying to understand these drugs and trying to understand the level of anticoagulation we need for our ECMO patients. And so, yeah, more information to come, I think.
I guess I have two quick questions. One is, assuming that I actually go forward with this bivalent heparin randomized project, do folks think that including children in that, and if you're including children, would you include children past the neonatal period, because the NIH gets very nervous about that? Or would you rather include children like the age of 6 or the age of 12? That's one question. Would you guys be willing to participate in something like that? And then just real quick, with the quadrox shortage and all that stuff that's come along, have you guys changed your oxygenators or your pump types or whatever? And have you noticed any difference in outcomes or clotting or bleeding with those changes?
So I'll go ahead and speak to the circuit, and then I'll let Tim take the other question. So we have had to switch our oxygenators. So our kids that are 13 kilos or less, we're using the AMG infant oxygenator, and with kids 13 kilos and up, we're using the Medtronic Nautilus Smart. I can't say that we've really taken a hard look, to be honest, at what we've seen as far as differences in our outcomes. I can't think of anything standing out to say these aren't working for us. So I guess that would be a soft no. We haven't seen any changes in our outcomes because of having to switch oxygenators.
I don't know that I can answer the first question. I'm pretty much a pure clinician. I don't do any research. Now, if you're asking me, would I feel comfortable randomizing a child as a clinician that does a fair amount of ECMO? I think the question is absolutely, especially we don't have good data to go by. So I think randomization is always the best thing to do.
I would say that the neonatal population, so that I would say that that requires a different study itself, because I like to be involved for the little ones, because right, the heparin and antithrombin in the neonates, it's complicated. But yes, I don't know, I cannot speak on behalf of here, but I think that in the pediatric ICU, the ECMO, yeah, will be, I don't know if the higher ups will agree in participating, but I think that's a very good study. But, yeah.
I think that's something we can send an email out about post-conference and see if we can get a focus group to get some more information on that once we can get our key stakeholders involved. I clearly don't have
What
any
pump do you
authority.
guys use? What pump do you use?
We're CentraMag PediMag. So we're system-wide CentraMag PediMag. That way, if we run into an issue where we have to support multiple patients on ECMO, we can easily borrow from our adult counterparts who also are CentraMag, with the exception of a cardio help for transport.
I would like one more comment to make is that in general, anticoagulation has largely been focused on the coagulation pathways, but we haven't really focused on platelets. And I wonder if there's opportunities there using, Aggrastat or other antiplatelet aspirin and nitric oxide through the membrane, as some have shown that reduces platelet activation and perhaps provides better outcomes for ECMO patients. There's certainly a study from Australia showing use of inhaled nitric oxide reduces or shows better outcomes in children undergoing cardiopulmonary bypass. So I wonder if that's another area that we should focus on.
Yeah, I was at Bartlett's lab last week, actually, before the ELSO meeting, and there's, this is their big thing, working on nitric oxide bonded circuits and all that stuff. And they're actually coming along pretty well and actually thinking about using it in other types of devices that clot, like stents or pacing wires or all this other kind of stuff. So that is an area that's really active, I think, in terms of research. And actually, for the adult guys there, yeah, we put everybody that has a stent or anything in them on aspirin or Plavix, as well as the anticoagulation, which I think actually is a good practice that isn't studied at all.
Another thing in terms of getting funding and raising more awareness in ways that in adults, right? Everybody says that it's all that if you could divide in males and females because of the hormonal changes and medication they're using, even can affect coagulation as well, and to see that as a different outcome, and that would be interesting as well, to like in your study to study separately that population. In peds, we're not that yet.
But yeah, you bring up a good point, Dr. Dalton. In adults, we have to worry about a lot of post-MI patients that are on dual antiplatelet therapy. And so just clinically, seeing bleeding complications in those patients where you start adding on bivalirudin and stuff makes me a little bit more cautious when we decide to start it in those patients that are usually anticoagulated to the gills post-procedure.
Thank you. I just want to extend a huge thank you again to all of our panelists here, Dr. Dalton, Dr. Thiagarajan. Thank you for joining us via Zoom. We know that you are tremendously busy. And then here at home in Pittsburgh, Tim and Xavier, thank you, or Federico, thank you so much for joining us. We really appreciate it. We're running actually a little bit ahead of schedule, which rarely happens for us. So we'll go ahead and break early for lunch, and then we're back, I think, at 1:30, and we'll continue on with our program then. Thank you.
Thanks for inviting us.
Okay, we're back from lunch. Thank you guys all for sticking around. We're going to go ahead and kick the afternoon off with some discussion on ECPR. So up next we have Dr. Rod Gazmezdada. He was here with us this morning. He's back with us again. He's going to talk to us about house arrest, in-house cardiac arrest, and ECMO.
Hello again, everybody. My name is Rod. I'm one of the cardiac intensivists here at the Children's Hospital of Pittsburgh. Thank you again to the committee for the honor of speaking to you all. So my topic is house arrest, in-hospital cardiac arrest, and ECMO, question mark. I think obviously this is something that is becoming more and more a standard across institutions. And I think the important steps in the progression and advancement of optimizing outcomes in this area. First, understanding the etiology and risk factors for pediatric in-hospital cardiac arrest. As time goes on and our patient population changes and the risk factors on the outside change, discussing candidate selection and outcomes of pediatric in-hospital cardiac arrest, especially as technology changes and our understanding of how to best optimize the use of the mechanical components of ECPR change and improve. The best way to ensure good outcomes is to prevent arrest altogether. So again, talking about some preventative measures we do here in our CICU to prevent the need for ECPR, or at least prepare for it should the worst come about, and then review successful strategies. So I always like to start with the case conference just to set the mood. 2-month-old infant female with heterotaxy, unbalanced complete AV canal defect, who underwent PA banding due to being of small size, a lot of other comorbidities, didn't undergo full repair. So had prolonged recovery in the CICU related to respiratory failure for multiple issues, transferred finally to the acute care service for continued management of heart failure, feeding and growing, et cetera. That night after transferring, developed rapidly progressive worker breathing, pale appearance, hypotension, poor perfusion, lactic acidosis. Urgently brought to the CICU for intubation and management, continues to have hypotension despite fluid resuscitation and vasoactives. As the resuscitation event goes on, develops bradycardia, poor pulses, and a CICU arrest page is sent out. So in this situation, what should be going through the team's mind is, okay, when this is all done, let's debrief and think about how we could have prevented this arrest altogether. Was there an opportunity to or not? And then during, before, and after, what will be or what is our cannulation strategy in the moment. And that can be something as easy as someone immediately post-op, okay, we're gonna go centrally. Or if you're now 14 days post-op, well, is central really still an option for you? Or you're gonna have to consider your peripheral options. Oh, by the way, this patient has had 4 or 5 different lines at this point, including areas that are more easily accessible for an emergent cannulation, such as the right IJ. Oh, nope, it's clotted. What was the last ultrasound result? Where else can we go? So these are all things that are best figured out well ahead of time. And the age-old question now is to give epi or not to give epi, right? So how will your outcomes be affected, knowing that ECMO is going to be your rescue from this situation? How much epi do you give to ensure that you're supporting the patient throughout? We know early epi helps improve success in getting out of a cardiac arrest situation, but if you're in it and you're just waiting to cannulate, how long and how much do you give? Okay, now that we're successfully cannulated onto ECMO or in the process of getting there, how do we optimize our hemodynamics to optimize end organ function afterwards? So firstly, let's take a way step back and really define what ECPR is, or extracorporeal cardiopulmonary resuscitation. It's extracardiac life support, that is extracorporeal life supports are utilized during cardiac arrest prior to return of spontaneous circulation and cessation of chest compressions. The failed CPR definition varies depending on the papers that you read. It can vary anywhere between 10 to 15 minutes. And really, the timing of ECMO deployment can vary depending on underlying patient diagnosis and their access points, local resources, workflow, staffing, et cetera. This is now older data, but in the ELSO summary in 2016, eCPR made up about 9% of ECMO cases in the registry. This number continues to grow. And 16% of children less than 18 years of age who received CPR for greater than 10 minutes ended up going on to ECMO through eCPR. So the reason that we're doing it is that we're seeing that outcomes are improving. If you look at papers describing success over time, whether it's all comers or cardiac patients, you find that survival can vary depending on institution, resources, availability, the patient population that they care for, and it can range anywhere between 35 to 75% for survival to hospital discharge. Overall, eCPR increased survival with an odds ratio of 1.7 and improved neurologic outcomes with an odds ratio of 1.8 versus conventional CPR. This is a study done by Lassa team in 2016. And I've highlighted in red on this graph over here showing that the highlighted numbers in red are cardiac patients versus all comers. And you can see when you select for the cardiac patients, given the fact that for the most part their reason for arrest is in relation to a hopefully temporary or fixable cardiac issue related to either post-operative or heart failure that will be bridged to something else, their survival tends to be a little bit better than other patients that may undergo cardiac arrest related to a extra cardiac disease, lung disease, sepsis, continued progression of an oncologic process, et cetera. This graph, it was reviews the 20-year experience of trends in in-hospital cardiac arrest and mortality among children with cardiac disease in an ICU setting. This starts back from 1995 and goes up to the current era. And you can see that both in terms of patients experiencing in-house cardiac arrest and patients in-hospital mortality related to in-hospital cardiac arrest, both are on the trend down. So further confirming the fact that eCPR programs do work. They don't just prolong life, they save lives and get kids out of the hospital eventually, especially in children with cardiac disease, and we're getting better at it. Again, to reconfirm the previously described finding that cardiac patients have improved survival with eCPR. Early mortality is usually associated with pre-ECMO factors as well as ECMO complications. So brain death, severe metabolic acidosis, pre-ECMO renal insufficiency. And again, this is something that's oftentimes misquoted or misthought, especially in the heat of the moment. The duration of CPR should not exclude patients. It does not affect outcomes post eCPR. So as long as there appears to be high quality CPR being given, if an institution has the capability of going on to eCPR, it should be offered or provided. Should the team feel like the other factors in play are conducive to a successful outcome. And the focus should really be on the quality of CPR prior and during cannulation, which sometimes can be hard to do in the process of intubation, placing lines, and cannulating in the neck. Oftentimes there starts and stops to the CPR and focus on medications, or you losing focus and really just focusing on getting onto cannulation, forgetting good basics of CPR. Pre-planning and deployment of ECMO be made as efficiently as possible and done as early as possible. I've included here one of our resuscitation action plans. This was a spin or our version of a quality improvement initiative that went out as part of the PC4 group that is our cardiac ICU collaborative amongst multiple institutions in the United States, where we look to improve outcomes surrounding arrest and cannulation onto ECPR should that be necessary. And you can see that for us, identifying patients that are high risk, identifying reasons that they might undergo decompensation or an arrest, specific factors, preventative measures that we can do to avoid an arrest, code med access, where we're going to give it, what we're going to give, what should we keep at bedside, and what our cannulation plan is. And you can see we have this little baby in the bottom corner here that where we will indicate and identify where we think a patient can or cannot be cannulated, where we're considering, or where there are clots in general, just to be knowledgeable of the fact that even if we have a good cannulation plan and for whatever reason it doesn't work, we know where the next place to go is. So a really good action plan ahead of time, identifying patients that are high risk. And this is not something that's just done for cardiac patients, it's done for patients who are admitted for non-cardiac reasons as well. Identifying high risk patients through artificial intelligence, review of the chart, and appropriate risk scoring can help in this process. So other cardiac specific considerations for us in the CICU, as I mentioned, vascular access, syndromes and comorbidities, timing since sternotomy, the cause of the arrest, shunt occlusion, surgical cath bleeding, arrhythmias, tamponade. Cardiac arrest during cath may be associated with worse survival with ECPR. The cardiac lesion and palliation, of course, is very important for us in the cardiac ICU and certainly affects your cannulation plan, whether a patient is single ventricle or not. Are they a Glenn Fontan? Do you have to cannulate both the upper body as well as the lower body? And where are you going to go afterwards? Is this something that can be clearly improved by a trip to the cath lab or the OR to resolve the underlying issue? Or is this something that's going to be long-term, persistent heart failure, AV valve regurgitation in a single ventricle patient that's not going to get better immediately if it's been intervened on, especially in the past? And what is your exit strategy off of ECMO? Looking at goals of care and bridge therapy is extremely important because hanging on ECMO is not a strategy, it's just failure to come up with your next step. As such, given the good outcomes associated with ECPR, especially in hospital, we'll talk about out-of-hospital arrest in the next session, but the AHA produced guidelines in 2019 with the PALS Focus update that said ECPR may be considered for pediatric patients with cardiac diagnoses who have in-hospital cardiac arrest in settings with existing ECMO protocols, expertise, and equipment. There is insufficient evidence to recommend for or against the use of ECPR experiencing out-of-hospital arrest or pediatric patients with non-cardiac disease experiencing in-hospital cardiac arrest refractory to conventional CPR. And hopefully with more data, these guidelines will continue to develop and change. Most importantly, the conduct of ECPR, both in the CICU and outside of it, is extremely important. One of our team members who has spoken already in this conference, Dr. Sanchez-Toledo, I'm sure if he hadn't used it, will use it at some point. The whole concept of the race car team in Formula One, how everyone comes together and knows their positions in an event that needs to happen quickly, efficiently, in the right way the first time. And we can use something similar in our units to ensure that everyone has a role, everyone knows their place, and can execute the task as efficiently as possible. Given the complexity of it, this is vital to success. On ensuring that you guys, that within your team, you have one strategy regarding vascular access consideration and the method of cannulation, uniform circuits across the institution, so you're not thinking about, okay, we're going to do roller head in this patient, or a conventional ECMO centrifugal circuit in this patient. Having uniform circuits across the institute does help eliminate some variability, and education can be uniform across the institution. Thinking about and being aware of the effect of epi on afterload after cannulation is obviously important, but some data may suggest that it might not make a difference. I'll show in a second. Access to blood, understanding where your emergency blood is, ensuring that if a patient's going to go on ECMO or you think will go on ECMO, having that blood available at bedside, or knowing where you can get it quickly. Anticoagulation protocols, extraordinarily important. As soon as you're on ECMO, especially in a non-surgical patient, you should be starting that anticoagulation right away. Clotting starts the second you start ECMO run, and that needs to be rectified by whatever your institution decides is best practice surrounding anticoagulation, and ensuring everyone does it the same way. If one person goes up by the heparin only a little bit and then the other person goes up a lot, there's confusion all across and you have variability in your outcomes. Post-arrest protocols are extraordinarily important and often forgotten in the heat of the moment of going on to ECMO, and then once it's done, everyone high fives and walks away. And in reality, your journey has just begun surrounding, okay, what's the appropriate blood pressure that you need to maintain to ensure good perfusion to the brain, kidneys, and other organs? What are ways that we can monitor the success of how the circuit is perfusing our body? Just because your blood pressure is okay and your heart rate's okay doesn't mean that you've sufficiently fed each of the organs. And simulation really does help bring this all together in a productive manner where education can be done in a low stress environment with low risk. Having everyone figure it out in the moment in light of a actual arrest is not the way to get everyone working efficiently as a team, similar to the Formula One team. This is a study I found interesting. It's looking at epinephrine dosing strategies during pediatric ECPR. It's a multi-center study that looked at, I think, 5 sites and compared patients that received after 10 minutes of ECPR, frequent epinephrine dosing and limited epinephrine dosing. And they found that while it wasn't statistically significant, there was some push towards significance in the non-survivor group to have more frequent epinephrine provided as opposed to less. Although largely, if you look at the p-values, there's no difference between the two. And the actual amount of epinephrine given throughout the course of ECPR is very different per episode, and not based on guidelines that we largely feel that for the most part, epinephrine is spaced appropriately. So more studies obviously need to be done to assess this, but I did find it interesting that they did not find ECMO flow 1 hour after cannulation to be significantly different between those that received epi more frequently and those that didn't. So again, challenging some of the dogmas that we hold to be true. Obviously, every good ECMO run starts with a good cannulation, but very soon after that, in addition to ensuring that all your organ systems are being supported adequately, the next step should be, okay, how do we get off of ECMO? In the cardiac setting, we think about addressing residual lesions, early cardiac catheterization to evaluate what those residual lesions may be. Are they significant? So in this study done by Kata, the group, cath within 48 hours after echo cannulation resulted in less respiratory complications, better survival at 30 days after an ECMO initiation than later catheterization. And applaud to all groups outside of the cardiac setting, but certainly including them. Avoiding fluid overload is immensely important. And here at CHP, we're very aggressive with renal replacement therapy attached to our extracorporeal device if we feel that we're not achieving our fluid removal goals with medical therapy alone, and avoiding other end organ dysfunction as well. We discussed during our small group session, how we look at protecting our lung during the process of being on mechanical support, as well as ensuring that our brain is getting the support it needs with EEG, ultrasound, head imaging, etc. Of course, every good question leads to more questions, and this is not one that's any different. So looking forward, and hopefully with more research, we can learn how to best integrate the latest CPR guidelines and recommendations into real-world ECPR procedures and processes, how to provide adequate chest compressions with central cannulation. Later on, we'll hear about the use of the Lucas device. We have used that in our bigger patients here at CHP fairly successfully to help maintain high-quality CPR in the process of getting a patient onto ECMO. What would be great is further biomarkers and surrogates for end-organ perfusion before an arrest and during, to ensure that our chest compressions are high quality, and it may help us titrate our medications, epinephrine, et cetera, to really provide the best source of pulmonary blood flow to our organs and ensure that they'll be as good as they're going to be after the arrest. And the use of AI and predictive algorithms to optimize outcomes as well, I'm sure will be a major source of research in the future. All right, and I have some references here for you, and I'm happy to take any questions.
I abandoned my computer. If there are any questions,
Yeah.
I'll let you know. Okay, great. Thank you, Rod. In keeping up with our sessions with ECPR, we're going to go ahead and move into our next talk, Can I Be Included? Inclusion criteria for ECMO for pediatric out-of-hospital cardiac arrest. We're going to have Dr. Raj Aneja give us that talk today. Raj is a professor of critical care medicine and pediatrics at the University of Pittsburgh Medical School of Medicine and the chief of pediatric critical care medicine here at UPMC Children's Hospital of Pittsburgh.
Thank you.
Click on the thing to advance.
Click on
If you click here, it'll highlight like everybody's appointment if you want it, or you click to advance.
go. All right. All right. Thank you for the invitation, especially to Merritt and Melita and the organizing committee for this conference. The topic that I was given was, can I be included, inclusion criteria for ECMO for pediatric out-of-hospital cardiac arrest. And this topic, when I started looking into it, was quite challenging in the sense because there's not a whole lot of publication for this topic. So we'll have to rely on some adult data, and then we'll try in the end to summarize the talk. So the story for us started a few years ago in 2020 when we had an 8-year-old previously healthy who was at a pool party, and as soon as he got out of the pool, he sort of stumbled and was noted to be in cardiac arrest. Mom started CPR. He was then brought to the ER as a level 1 trauma, actually, because he was in the pool. And there he was placed on ECMO in the ER. Subsequently, it was shown that he had an anomalous left coronary artery, which was repaired a few weeks later, and then he was discharged soon after that. 6 months after that story, the advanced reperfusion strategies for patients with out-of-hospital cardiac arrest and refractory VFib arrests, or the ARREST trial as it is called, came out. This was a phase 2 single center open label randomized control trial, which was done at the University of Minnesota Medical Center. And they randomized all consecutive adult patients to ACLS or early ECMO treatment. And their inclusion criteria were that you have to have a VFib rhythm or a pulseless VTAC. There should be no ROSC after 3 defibrillation attempts. You should be on a Lucas device. There should be an estimated transfer time to the ED of less than 30 minutes. And they had the standard exclusion criteria, which most of these studies do. In addition, they did have immediate access to a cath lab regardless of the presence or absence of pulse on hospital arrival, with the ongoing Lucas device for the mechanical CPR. The resuscitation was stopped if you had an end tidal of less than 10, a PO2 less than 50, or an O2 SAT of less than 85%, and if the lactate was 18. So with that background, let's look at their outcomes. The blue is the ECMO group. As you can see, 6 out of the 14, or about 43% patients, survived. And in the standard ACLS group, which is the one in red here, it was only 1 out of 15, so about 7%, give or take. And when you look at their outcomes, as you can see, initially, many of the ECMO patients in blue again had a worse score, but over time, because when they were discharged from the hospital, they were still in not a great condition. They had a prolonged hospitalization, they were deconditioned, therefore their functional assessment scores were low. But over time, at 3 to 6 months, as you can see, they actually had a cerebral performance category score of 1 to 2, which is a pretty good outcome. In comparison, the sole survivor in the ACLS category actually died around the 3-month mark before he could even have his assessment done, leading these authors to conclude that early ECMO-facilitated resuscitation for patients with outside hospital cardiac arrest and refractory VFib significantly improves survival to hospital discharge and functional status when you compare it to the ACLS resuscitation. Fast forward 3 years, and you have another trial that was done in Netherlands, where the EMS personnel are able to reach patients approximately 8 minutes after the arrest. And then they can take you to the hospital within 35 minutes or so. So they had enrolled patients between the ages of 18 to 70 years of age. Those who had received bystander CPR, had an initial ventricular arrhythmia, and did not have a return of spontaneous circulation within 15 minutes after CPR. And they had 160 patients, out of which 134 were included in the intention to treat population. Out of that, approximately 52 were assigned interventions in both the groups for extracorporeal CPR or conventional CPR. A few of them did not go on to ECMO because of logistic or failure to go on ECMO, but eventually all 70 were included in the follow-up, and all 63 were included in the follow-up on this side. When you look at the demographics, fairly similar in both groups. So as we talked about, the start of arrest to EMS arrival, about 8 minutes in both groups. Start of arrest to arrival at the ED, about 36 minutes in the ECPR group, 38 minutes, so fairly similar for both groups again. And start of arrest to ROSC, about 43 minutes in the ECPR group compared to 49 minutes in the conventional CPR group. What is also noteworthy is that the median interval between hospital admission and the initiation of cannulation was about 16 minutes. The median interval between start of cannulation and start of ECMO was about 20 minutes. But overall, the median interval here from start of arrest to start of ECMO flow was about 74 minutes, a little bit longer compared to the arrest trial, and that is reflected somewhat in their outcomes, which we will talk about. A stable ROSC was obtained in about 26% in the ECPR category and 31% in the conventional CPR category. So not much difference in that way. And when you look at their outcomes, there is a 4% difference favoring the extracorporeal CPR, which was non-significant based on the p-value. The neurologically unfavorable was sort of the main reason to stop treatment in the ECPR group, while failure of other options to be present was the main indication for the conventional CPR, where treatment was discontinued. So use of ECPR or conventional CPR, at least in the second trial, was almost similar. There was a 4% non-significant difference between the two. And some of the issues were multiple centers were involved. They didn't really have an EMS protocolized approach to the study. And we talked about the 74 minutes, which was a little bit different than the arrest trial, which was a single center, survival to discharge about 43% in the ECPR group as compared to 7% in the single center group. So let's take a step back and look at the scope of the problem. So EMS services transport about 347,000 adults or 7,000 children. Some people suggest this number may even be higher than 7,000 children to about 10,000 children with outside hospital cardiac arrest each year. This translates roughly into 2 to 8 children per 100,000 person years. The hospital discharge rate for this group of patient population is about 6 to 27%. And these results are really unchanged over the last decade. And that's been the push to think of other things, including ECPR for this group of patients. To prove that point, there's a prospective study which was done by the Japanese, which enrolled 263 out-of-hospital cardiac arrest pediatric patients. The average age in that group was 6.3 years, in which defibrillation was used in 5%, ECLS was used in 2%, and target temperature management was used in 6.5%, along with epi being the standard, which is what you would expect. The PCPC score of 1 to 2, which was considered as a good outcome, was only present in 6 and 2% of these patients, a number that did not change 3 to 6 months after these patients were discharged. When you look at the American Heart Association guidelines for CPR and emergency cardiovascular care, the 2020 output, you see they are asking the same questions we are asking today, that which populations are most likely to benefit from ECPR, and what is the role of ECPR for infants and children with outside hospital cardiac arrest and in-house cardiac arrest due to non-cardiac causes. And they're using the Steen's formula for this, in which you expand the medical science, you develop educational efficiency, you increase the local implementation, leading to an improved survival for this group. When you look at, there was another consensus guideline. This was mainly adults that they had gone after, which was age. This was mainly percutaneous cannulation for ECPR situations, and age, of course, less than 75, witnessed arrest, shockable rhythm. And you'll see these themes consistently come up in most of the adult studies, which we have to rely on for this talk, partly because of not much data on the PED side. Witnessed arrest, shockable rhythm, no prolonged downtime without CPR, and they also considered end-tidal CO2 more than 10, and aggressive ICU care, and if the physician and surgeon agree for this. What is the pathophysiology really in cardiac arrest? So what happens is that once your blood flow to the brain ceases, your ATP production is down, which leads to an increase in lactate. This also leads to impaired functioning of the sodium channels. As a result, there is cell swelling. There is also calcium that sneaks in through these NMDA receptors, which also leads to mitochondrial dysfunction. As a result, you have these reactive nitrogen species and reactive oxygen species, which lead to neuronal cell death. The second phase of this is the reperfusion injury, which essentially is the balance or the imbalance between the supply and demand between all of the requirements for the brain, the lactate, the glucose, the oxygen. You do have some microthrombosis that is happening in the microvasculature, and a lot of it is then governed by the hyperoxia, the hypoxia. It could be hypercapnia or hypocapnia, could be hypotension, hypothermia. All this contributes to reperfusion injury. We'll talk a little bit more about calcium, where you have this glutamate which is released from the ischemic cells, and then it sort of tags onto this mGlu receptor, leading to a downstream signaling pathway, which releases the calcium for the endoplasmic reticulum, leading to an increased calcium role. This brings in more calcium, and as a result of this, a lot of the calcium-dependent enzymes and death pathways are activated, which lead to cellular damage. In addition to this, you have inflammation, which is also sneaking in. You have microglia that are activated. There is IL-6, IL-1 beta that is sitting around. These also help in release of chemokines, as a result of which the adhesion molecules are expressed, and these monocytes start to go and sort of propagate this whole inflammation chain that goes on. resulting in severe brain injury, which leads to generally affects all these areas that are highlighted here. You have the thalamus, which you generally tend to lose the executive functions like planning and decision making, along with flexibility. Cortex is gone, which is the complex attention and processing speed. You have the hippocampus, which takes away the learning and the memory part of things. And then you have the basal ganglia, which takes away the depression, which gives you the depression, the anxiety, apathy, and the psychotic symptoms. And what you're really trying to do with ECPR is provide the systemic organ perfusion despite the absence of ROSC. Remember, the conventional CPR can only deliver about 25 to 30% of the cardiac output. So you're trying to get above that. You're trying to increase the coronary perfusion pressure, the rate of ROSC, and successful defibrillation. You're also trying to achieve and sustain targeted temperature management via the VA ECMO circuit. So these are all the benefits of ECPR, which generally sometimes are not highlighted in the day-to-day work. Now let's look at what is the difference between adult and pediatric outside hospital cardiac arrest with whatever limited data we have. So adults, 60 to 80% of patients that survive outside hospital cardiac arrest have an initial shockable rhythm. There are newer sort of reports that seem to suggest this number of 60 to 80% may be a little on the higher side, that these numbers may be closer to 25 to 40%. But regardless, this data is out there. Sorry. The refractory VFib generally portends a poor prognosis. More than 40 minutes of CPR, almost all will die. 70 to 85% presenting with outside hospital cardiac arrest, refractory VFib have coronary artery disease. Compare that on the pediatric side, it's a rare event, less likely to be cardiac. Only 10% is shockable. It is possible that the high prevalence of respiratory causes is something we have to be cognizant about. There's low survival, particularly in age less than 1 year. Part of it is sometimes a lot of these kids tend to be also non-accidental traumas that are under 1 year of age. And then pre-existing lung or airway disease, there's some data to suggest may be associated with increased survival. And obesity in general for the pediatric side has a lower survival with outside hospital cardiac arrest. Asystole is the most common initial arrest rhythm, and the outcomes are better if there's VFVT or a shockable rhythm compared to asystole. When you look at the outcomes per se, adults in general have a better outcome if there is no CPR going on when they arrive at a hospital. If less epi doses were used, some of it is really intuitive. If the CPR duration is short, and if the CPR is less than 20 minutes, that's generally the best indicator of survival. You have worse outcomes if there is a lower post-arrest pH, a high blood glucose, or a high lactate that is present. Peds, there is very little data to support much of this. And if I were to draw a word cloud in this field over the last 5 to 10 years, that's what it probably would look like. Some of it we've touched on. So let's go over some of the factors that seem to affect outcomes in this field. No flow interval, patient age, quality of CPR, underlying cause, timeliness of ECPR, and transport time. I'll only be able to take some of these factors, and then some I'll just show you some PICO studies data which kind of puts it all together. Why is the no flow interval important? The no flow is important because the EMS have to determine if they need to start resuscitation or not. If the ECPR program sometimes may have a cutoff, you need to have some idea about clinical futility. And no studies really ever shown a threshold for a no flow for a favorable outcome. But this study, I thought, did that to some degree. So what they did is there were two ROC trials, or resuscitation outcomes consortium trials that were done, which were, ROC is a network of about 10 North American clinical sites covering about 24 million people and over 35,000 square miles. And what they did is they had these two studies. Both trials had neutral results. There was no flow interval, which the data they had for, and the neurological outcome. So they wanted to sort of see if they can do an analysis to understand this. In addition, they also carved out a subgroup ECPR eligible, which was age less than 65, non-asystole initial rhythm, and more than 30 minutes of professional resuscitation till ROSC. So this was the data set they had, about 43,000 patients. They took away the bystander, the unwitnessed, the non-cardiac, if there was no outcome data available or time of CPR was not recorded, and they ended up with about 7,300 patients. And then in addition, they carved out an ECPR group, which was about 150 patients or so. So in this group, the demographics, the median age was 70 years, 66% male, shockable rhythm 31%, ROSC about 45%. Median no flow interval was about 8 minutes with an IQ of 6.4 to 10. And the survival to hospital discharge was 11%, and 8.4% had a favorable neurological outcome. What was more interesting was they kind of divided the whole no flow interval into 2.5-minute aliquots. And as you can see here, that in the full cohort, there was really no cases with both a no flow interval more than 20 minutes and a favorable neurological outcome. So that was the limit that they found, was 20 minutes in the full cohort. In the ECPR group, when they did a similar division, the numbers were small. So, and the authors don't really comment what that meant in terms of this, but they found that 10 minutes was sort of the, if there was a no flow interval exceeding 10 minutes, then there was no favorable outcome. So, as I said, they didn't really comment on this part per se. So probability of survival with a favorable neurological outcome decreases by 13% per minute of no flow interval. I thought this was a powerful statement in itself, 13% for every minute of no flow interval. And favorable neurological outcome with a no flow intervals up to 20 minutes is possible. That's what this group has shown. So I think most of these studies that come up with a 30-minute is very, very reasonable. Some of the other criteria that we kind of touched on was taken on by this study, which was more a PICO-based study of population intervention comparison and outcomes. And they took age more than 12 years as cutoff. So I'm sure there were some pediatric kids in here. And what they did is they took both outside hospital cardiac arrest and in-hospital cardiac arrest and kind of lumped them together. And then studies with less than 5 patients were excluded from the overall. And what they found in their database search was started off with 3,000 and finally ended up with about, I shortened the table just so that it can come clearly on the slide, but they ended up with about 67 observational studies. 14 of them were prospective and 53 retrospective studies. And then for the meta-analysis, they used about 56. And in this, the criteria, this one is for the retrospective studies. So I'll come back to it, but overall, if you look at it, they had a favorable neurological outcome in about 21% of the cohort. The survival was about 28%. And the prospective studies are sort of similar to the overall, including the retrospective. But outside hospital cardiac arrest had a favorable neurological outcome of 16% in this group, and in hospital was about 28%. When you look at the prospective studies, there were 14 total. 6 of them were outside hospital and 2 of them were in-house cardiac arrest, and 6 were mixed. Median age 52, and it's the same set of common criteria that they have, which we've talked about: age, witnessed arrest, bystander CPR, shockable rhythm, and less commonly, the studies relied on lactate, end-tidal CO2, and signs of life. Time to ECMO for this group was about 74 minutes with a confidence interval of 55 to 94 minutes. And what they really found is that the more the inclusion criteria are met, when they did meta-regression, they found that the higher number of inclusion criteria, they correlated with a favorable neurological outcome as the number of inclusion increased. And that's what they sort of noted. When they went to the retrospective studies, they had 53 total. 17 of them were outside hospital cardiac arrest. 11 were in-house, 24 were mixed. Median age 56, 74% male. Criteria almost similar as the prospective studies: age, witnessed arrest, bystander CPR, shockable rhythm. Less commonly, they found lactate and end-tidal CO2. And time to ECMO was 57 minutes because, at least in this retrospective group. They didn't find the similar conclusion that they had come to for the prospective studies when they looked at it, that the higher number of inclusion criteria did not correlate with favorable outcomes. So it's sort of difficult to say because a lot of them were retrospective studies. Sometimes the data are missing what if it had any impact or not. But overall outcomes, I think we relied to a little bit, we talked about a little bit. Outside hospital cardiac arrest was 21%, in-house was 28%. Shorter rest to ECMO flow time was associated with improved outcomes, as you would expect. An increased number of selection criteria was associated. Hyperoxia is one thing we talk about a lot. So there is one study that has looked at that. That's the Japanese registry in which they retrospectively analyzed it. Age was more than 18 years and about 900 patients total. So they divided into 3 groups: normoxia, moderate hyperoxia, and extreme hyperoxia as defined by PO2 of more than 400 millimeters of mercury. While the moderate hyperoxia was not associated with a 30-day neurological favorable outcome, let's see what happens with extreme hyperoxia. Now, it might be interesting to point out that almost 500 out of 900 patients were either moderate or extreme hyperoxia. So that kind of gives you. The outcomes do tend to drop off a little bit. 30-day survival in the normoxia was 36%, 34% here, 27%. But when you look at the favorable outcomes, and they did a multivariate logistic regression analysis to see moderate hypoxia was not significantly associated with neurological outcome compared with normoxia as a reference. But when you look at the extreme hyperoxia here, it was significantly associated with the deterioration in neurological outcome compared to normoxia as a reference. They even created this cubic spline curve with a log of odds on the y-axis. So a log of 0.0 would mean that the favorable neurological outcome was about 1. So if I go to the peak of the curve and just drop a line down, it's somewhere around the 200 some mark, somewhere here. So we should try not to be in the extreme hyperoxia group for sure, as it will be associated with worse neurological outcomes. And similar data is there, more not in the pediatric ECPR world, but at least in the outside hospital cardiac arrest world. Some pitfalls: the effect of ECMO duration and LOS were not accounted for. Blood gas data was missing for many patients. ECPR practices were different in different institutions. What about pH? So similar study has been done for looking at pH, in which they had sort of split it into 3 tertiles, one being more than 7.03, the second one being 6.8 to 7.0, and the third one being less than 6.8. And for the most part, the demographics are fairly similar, but the primary outcome in tertile 1, which was a 1-month survival with favorable neurological outcome, was 30% here in the tertile 1, the pH more than 7.0, and it was about 9 to 10% for the other 2. And this is what is sort of shown here too. So pH does have a role to play in this story. What about other parameters in the sense of focused echo, end tidal, arterial blood pressure, NIRS? Not much data is there. NIRS, there are 2 studies that have looked at, and one has a cutoff of 16%, the other one has a cutoff of 30, which may be associated with it. But I think maybe as a group forward, we can kind of come up with these criteria as we start putting these patients on and try to get a baseline before they come in. But mean end tidal more than 20 during pediatric in-hospital CPR was not associated with survival to hospital discharge. In fact, end tidal was not even different in survivors versus non-survivors. And what they found is return of heart rate more than 60 in less than 6 months of age, and end tidal between 17 to 18 corresponded to the highest sensitivity and specificity with an area under the curve of around 0.83. And the other thing that was notable in the same paper was that if you increase the ventilation by 10 per minute, the end tidal will drop by about 3. That was another finding which was present in this. So in summary, the inclusion criteria that have consistently been reported in the field is age, comorbidities, witness to rest, bystander CPR, and shockable rhythm, much more for the adults. The other factors include low flow duration, shockable, lower lactate and higher pH levels. There are newer inclusion criteria that are being considered for other studies, end-tidal CO2, ROSC, signs of life. And while these criteria have been shown to have prognostic value in individual ECPR studies, the relative contributions to clinical outcomes are yet to be tested in a large ECPR cohort. It is estimated that 5 to 10% of these outside hospital cardiac arrest cases will meet the ECPR eligibility criteria. But I think if we make it too stringent, this will make the ECPR infrequent. So we just have to be careful. The arrest trial data and the PROG data are encouraging, and generalization of these results in inclusion criteria remains to be seen as ECPR expansion continues. Thank you.
Thank you, Raj. That was a great talk. Our next talk today is going to be brought to us by Dr. Katie Moynihan. Dr. Moynihan is the Assistant Professor of Pediatrics at Harvard Medical School, and she's an attending in the Department of Cardiology at Boston Children's Hospital. Dr. Moynihan is going to talk to us today about candidacy versus cannulas, the ethics of ECMO candidacy decisions. Dr. Moynihan, we have you on the line. Thank you so much for taking time out of your day to join us.
Absolute pleasure. Thanks so much for the introduction and also for the invite to talk today on ECMO candidacy decisions. It's a pretty good segue to follow on from the last talk, really. So it's very nice to be here, albeit virtually. I have no direct conflicts, and these views are my own. As you can probably hear from my accent, I trained in Australasia but work in Boston, as was mentioned, in the cardiac intensive care unit. And today I plan to give or offer 5 guiding principles for an ethical and inclusive approach to ECMO decision-making. But I'll start out with the underlying rationale for these principles. And I don't really need to explain to this audience why these decisions are complex. There's high mortality and morbidity. It's instituted emergently, with death often the alternate. Use is increasing, as is societal awareness. Really, the ECMO secret is out, and we're living in an era where patients and families have greater access to information of varying quality, but also a greater expectation of participating in their medical care. And then it's also resource intensive. But I'd want to clarify that use is not just increasing, but expanding and changing, such that many traditionally held contraindications are now no longer absolute or even relative in many centres. There's emerging data, as some of which you can see I've shown here, that supports use in high-risk conditions that were previously considered contraindications, things like prematurity, oncologic diagnoses, trisomy, and neurological complications. And their mortality may be higher, but not always so. And so this leaves us with profound prognostic uncertainty. And underlying that complexity and uncertainty is significant variability in practice. So even when meeting the same severity of illness criteria, willingness to cannulate varies quite dramatically across all of these comorbidities. So what that means is not only is standard care different between locations and providers, it's also changing over time, and we don't all agree on what that is. And then there's bias, and this is certainly a potential driver of inequitable ECMO utilization and outcomes. And even if implicit, it does underscore the need for transparency in data collection at the institution level, as well as attention to accountability for our decisions. This scoping review considered variability with a health equity lens and examined associations between these social determinants of health and ECMO utilization or outcomes. Ultimately, 148 studies were identified that looked at race, ethnicity, socioeconomic status, or payer variables with ECMO outcomes or utilization. And overall, disappointingly, data quality was poor with numerous analytic shortcomings. But overall, we found that the direction of associations between social determinants and ECMO outcomes or utilization were inconsistent. Here you can see in this figure that the circle size represents the proportion of publications for each outcome that is observed for underrepresented or under-resourced populations. And you can see along the middle row there that most studies found no statistical association. However, for those with a statistical association, they strongly favored more adverse outcomes or lower utilization for underrepresented or under-resourced populations. So this indicates that bias is certainly a potential issue. Now, with marked population heterogeneity, the importance of loco-regional and temporal contexts, subjectivity in perceived benefits and burdens, and also what constitutes a good outcome, there's such limited capacity for us to prognosticate in any evidence-based way. And so it's not surprising that there's limited existing guidance or decision support frameworks that inform ECMO decision-making. And really for these reasons, I think that there are enormous barriers to creating a decision-making algorithm grounded in clinical conditions. So I argue that a protocol defining specific uniform clinical criteria as indications or contraindications to ECMO support are really impossible. But at the same time, with this potential for disparate use, we clearly need guidance. And so then how should we decide for ECMO? I think it's really notable that ECMO shares similarities and differences across CPR, transplantation allocation, and use of other life-sustaining therapies, each of which have different approaches to decision-making, which may inform how we approach ECMO decisions. Now, CPR is time-critical, instituted emergently, and is highly burdensome, but it's provided for a finite short term. And this exists as a default option, requiring patients or families to opt out. And I think most of medicine hope that's not where ECMO is going. Initiation of other organ support technologies like dialysis or VADs and home ventilation are more value-based decisions with longer-term implications. And these decisions are generally shared. But compared with those other devices that I mentioned, ECMO is relatively more resource intensive and burdensome. And as a temporary treatment modality, use is restricted to the ICU. And finally, transplantation. So this is a long-term life-sustaining option, but organs are scarce. So while patients and parents may opt in, ultimately it's a medical team that holds decisional authority for allocation. And ideally this follows a standardized process. However, in practice, it's hard to perfectly implement that. At the same time, while ECMO could be considered resource limited, we do have much greater agency over its use than we do for organ allocation. So even though shared decision-making is the recommended model in critical care, adult providers certainly favour medical decisional authority for ECMO. And now arguably this is paternalistic, as patients and families should be offered the choice to pursue goal concordant, high-risk, high-reward therapies, especially as we as providers are notoriously bad at estimating quality of life. On the other hand, it could be justified to maintain stewardship over this intense resource and also to protect families from decision-making burdens. It's notable that in contemporary pediatric healthcare, there is greater deference to parents, where only half of surveyed clinicians would override parental refusal or demands for ECMO. And so while absolute certainty may not be attainable, it doesn't mean we shouldn't strive to improve. And so with that, I'll not pretend to offer answers, unfortunately, but rather some guiding principles developed with a lot of international expertise and input, which I'm grateful for. So these 5 guiding principles include discussing recommendations for an ethically supported definition of beneficial use of ECMO, the need for a precision approach using personalized communication and emphasizing the importance of preemptive conversations, how a deliberate process-based approach to decision-making that is robust and fair is a critical component, The longitudinal aspect relates to the dynamic nature of ECMO candidacy, that these principles are relevant regardless of if the patient is cannulated to ECMO or not. And so decisions and the informed consent process need to be regularly revisited throughout the patient care continuum. And finally, there needs to be an exit strategy, including an approach for conflict. So the first guiding principle defines beneficial ECMO use, and we name 2 conditions where it's appropriate for ECMO to not be offered. First, where ECMO is technically or mechanically infeasible. And second, where ECMO as a means of providing temporary cardiorespiratory support provides no biologically plausible or physiological benefit. Outside of these scenarios, ECMO could or should be initiated if 2 prerequisites are met. That is, ECMO is deemed to be a clinically beneficial therapy, so thought to be professionally deemed suitable to achieve a therapeutic goal from cardiorespiratory support, and it aligns with the patient or surrogate decision makers' goals and values to achieve a patient goal. And so both of these 2 criteria here are necessary and important because while families and surrogates do have a negative right to refuse a therapy, even if clinicians believe it's beneficial, they cannot demand therapies or specific medical care that's not deemed to be medically indicated. But overall, including both of these prerequisites indicate that with few exceptions, decisions regarding ECMO initiation should result from shared decision-making. Clinicians, however, should fulfill their fiduciary responsibility within shared decisions by providing directive guidance, weighing burdens with the ability to achieve a therapeutic goal and patient goals with ECMO. And I'll talk more about that when we touch on communication. But as a team, we think that this novel, more contemporary definition challenges the classic bridge paradigm of ECMO use, with the advantage of encompassing more ethically supported uses of this technology as they emerge. And we're seeing them emerge already. So things like possibilities for use solely for the purpose of organ donation, to provide a good or dignified death with family present, avoiding death in the operating room, for example, and who knows what in the future. So the second guiding principle relates to preemptive, personalized communication. Now, if we think ECMO won't be of benefit, then we should have preemptive conversations with our colleagues and then with the families. ECMO should not be performed to avoid having a difficult conversation, and indiscriminate use of ECMO is not recommended because it is highly invasive, may cause suffering, and could be considered a scarce resource. So we have to be transparent when we outline the benefits and burdens of ECMO, and that type of communication should be personalized. And there is a range of ethically justified clinician directiveness that we can use when guiding families. And for ECMO, arguably we can and should use the extreme end of that spectrum and be highly directive in providing recommendations for or against ECMO, against if we don't think that the benefits outweigh burdens. This is important because one day we all know ECMO support looks like this, but it doesn't always go smoothly. And so transparency is really critical to avoid misinformation. Like CPR, there are unrealistic portrayals of ECMO. This is a study published recently which found that of over 200 references to pediatric ECMO in the media, almost 95% implied survival. So we have to be honest about the limitations of what ECMO can achieve and ensure it's clear that as a support measure, ECMO affords temporary stability, and where curative therapies exist, may buy time for them to work. However, ECMO should be framed as a bridge towards a goal. And so if ECMO is unlikely to achieve treatment or patient goals, or will be more burdensome than beneficial, then we should make sure that's clear and make a strong medical recommendation to not cannulate. This is some phrasing that is an option to be used here. And I'll name that it's a complex and nuanced thing to discuss with families. And ECMO can be explicitly named in that conversation or not, depending on the patient or circumstance. Preemptive conversations are helpful even if the patient is deemed an ECMO candidate at that time. They can prepare families for a high likelihood of adverse outcomes in that patient on ECMO, describe how time-limited trials or goal-oriented use of ECMO exists, and also when the decision would be reviewed and or circumstances where ECMO would not be appropriate. An institutional ECMO candidacy threshold is influenced by a myriad of factors and will inevitably differ even between two centres within a few miles of each other in the same US state, as well as over time, as we've already seen. But regardless, our decisions need to be individualised to the specific clinical scenario and patient, and also fair and robust. And so the third guiding principle is that our decisions should be process-oriented. That is, decision-making should follow a robust, structured process. And the rationale here is that it's ethically imperative that each individual patient receive a fair and comprehensively reasoned decision about the beneficial use or ECMO candidacy for them. And so we advocate that for this process to align with principles for accountability for reasonableness or procedural fairness frameworks, which promote legitimate decisions. And so these frameworks have 4 core principles, which include that rationales be readily accessible, grounded in contextually relevant reasons, with the opportunity to revise based on new information, and also with a mechanism in place to ensure that these other conditions are consistently met. And so consider that while reasonable people may disagree on how a situation was ultimately navigated, it is possible to agree on a fair process, such as these steps shown here. So regardless of an individual's agreement with the final determination, if it's arrived at via this legitimate decision-making process, then clinicians, patients, and families can be confident that they've been afforded the fair deliberation that they deserve. The fourth principle is that candidacy should not be considered a singular decision made prior to cannulation. You'll note that our definition of beneficial use is really longitudinal, so it's applicable to both ECMO initiation and continuation decisions. So these decisions and the process to determine if ECMO is beneficial should be reapplied throughout the patient care continuum, because clinical status and values are dynamic. Things change. Patients who were not candidates at one stage may improve, and so ECMO may now be clinically reasonable. Similarly, patients deemed candidates initially may develop complications, or families may perceive burdens, and so the therapy is no longer clinically beneficial or value aligned. In the same way, our informed consent practices must be modified, not necessarily required prior to cannulation, nor the product of a single conversation at a discrete point in time, but rather provided in an ongoing and dynamic way that adjusts and is flexible to the patient's evolving condition. Now, there are key content features of our duty to inform, which still have to be satisfied, but it doesn't have to be performed prior to cannulation. These occur through iterative conversations. Now, ideally, decision-making and informed consent processes are started in advance, but they take time. And so we all know that we cannot always fairly determine if ECMO is beneficial prior to the need for cannulation. And as the presence or absence of cannulas should not obstruct a good decision, it is ethical to provide ECMO support as a bridge to decision, to buy time to make that decision a fair one. We all know, though, at least for now, ECMO is not a destination therapy. So ECMO as a bridge to decision still requires a decision or a goal. And so because of this, we need to have an exit strategy. And this is the 5th guiding principle. And it's really important because it's not ethical to provide ECMO to those who won't benefit from it, both because this is not beneficial use for the patient and because we have an ethical obligation to allocate healthcare resources justly. So if following the aforementioned process, it's determined that ECMO is not beneficial, then it's essential to have a strategy to facilitate discontinuation of support. And the legitimate process that I just outlined as the third guiding principle, in combination with high quality communication, will go a long way to promote ongoing beneficial use. And so as part of the process, the rationale for our decisions should be transparent and documented. And rationales should be able to be articulated easily to our colleagues and families. And this will both hold institutions accountable to make decisions fairly, but it will also help discussions with families if things change and ECMO is no longer considered clinically beneficial. So families can understand how that journey has changed things. Now, ECMO mortality overall is just under 50% for children. And so realistically, the exit strategy should be activated soon after initiation. And ECMO should be portrayed as a temporary intervention towards a specific goal. At the same time, the process used to determine or define if ECMO is beneficial or not should also be described to families early on. And part of the modified informed consent process should include discussion of circumstances where ECMO is no longer clinically beneficial or no longer effective to achieve intended goals. This means that families will hopefully be prepared from the outset that if further time on ECMO will not help, recommendations will be provided for discontinuation of support. And in the same way that we can be highly directive in preemptive conversations recommending against ECMO cannulation, we can also make strong medical recommendations to guide families towards discontinuation if ECMO is not achieving the treatment goals. And again, here, high quality communication within a therapeutic relationship is key. We have colleagues and subspecialty teams that can help. We certainly need more data on when, who, and how to integrate their expertise. And divisions and organizations really need to define a plan for conflict. While simultaneously working to regain societal trust in medical decision-making, we need to have some frameworks in place to deal with conflict, because despite having a legitimate process that aligns with procedural fairness principles and using high quality communication, it doesn't always work. And there is a potential for conscientious objection to ECMO discontinuation to be concerningly on the horizon or even already here. This is a path for addressing conflict that was endorsed by multiple critical care societies, and it offers a process-based approach to address disagreements. I know that similar approaches are used by many institutions for conscientious objection to discontinuation of therapies following death by neurological criteria. So, in conclusion, beneficial use of ECMO in contemporary healthcare should have clinical and value-based aspects in the vast majority of cases. This definition is applicable across initiation and continuation decisions, and we hope will stand the litmus test of time for broad future uses. Precision medicine is translatable to communication, to all communication. We need to personalize our approaches to decision-making with an emphasis on transparency, and for ECMO in particular, the provision of directive recommendations around beneficial use. As all patients deserve a fair decision about their ECMO candidacy, a robust, deliberate decision-making process is a critical component. And so organizations need to explicitly define their process and how it aligns with principles supporting procedural fairness. ECMO decision-making and informed consent should be considered longitudinally. That is, as dynamic, iterative processes akin to clinical care. While ideally, robust decisions are made in advance, due to time constraints, it is ethical to support on ECMO as a bridge to decision. At the same time, we need to remember that a bridge to decision ultimately needs a decision and a goal. And finally, we need an exit strategy. This should be characterized by high quality communication and transparency within the legitimate decision-making process, which will work for the vast majority of cases. but also a plan for conflict. I'll stop there. Happy to take any questions or via email if helpful.
Thank you, Dr. Moynihan. That was a really great talk. Dr. Villegas saw you speak at the World Congress meeting, and when actually, I think it was even before she came back, she contacted me saying that it was important that we try to get you on our agenda so that you could give us this same talk, because it is really important information. So we're very appreciative that you made time for us. Thank you so much. And hopefully we'll look forward to having you back next year if you'll join us again.
Absolutely, anytime. And please, I've got my email address there. If anyone wants to email any questions or clarifications or challenge things, it'd be great to have a chat. Thanks all.
Great, thank you so much. We're running a few minutes ahead of time, so we're waiting for Dr. Bakoris to join us for his ECPR case discussion. So in the meantime, while we're waiting, I'm just gonna go ahead and review a couple of the items for claiming credits. I sent an email out a little while ago that will give you instructions on how to go back to that UPMC CCEHS website and the steps to follow in order to be able to fill out the evaluation and claim your credits. I also included in that email the YouTube links for the videos that will be on the Congenital Heart Academy's YouTube channel. They're sectioned off by day, so it should be easy to find whatever talks you want if you still have the agenda. We had a couple switches, but really not much, so it should be easy to find whatever it is that you're looking for. And as a reminder, if you are a perfusionist, please send me a private email stating that you'll need the ABCP credits for the meeting, because our credits are calculated a little bit different for perfusion. The AMA credits are always come in a little differently. So our credits as perfusionists are a little bit different. So don't forget to shoot me that email so I know that you also need that certificate as well. Dr. Bakoris has joined us in the auditorium now, so we're going to go ahead and get his case report up here. In case you guys don't remember, Matt was with us earlier today for the CICU fireside chat. He is one of our intensivists in the cardiac critical care unit here at UPMC Children's Hospital of Pittsburgh, and he is currently acting as the interim director of the CICU here for us. And I'm going to turn it over to him so he can give us an ECPR case report.
All right, hey guys. Yeah, thanks Merritt and Dr. Villegas for inviting me to speak. Like Merritt said, my name is Matt. I'm one of the pediatric cardiac intensivists here. And they asked me to give a talk about a mutual patient of ours who had the unfortunate privilege of going through ECPR. So we'll talk about her case. Briefly, I have no financial disclosures, and permission was granted by the patient's family for me to include some photos of her, both pre and post ECPR, as well as some pictures from her medical stay here. So this is LG. This is a 2-month-old female when we got to know her. She was being followed by outpatient cardiology after discovering that she had a heart murmur in the newborn nursery, and postnatal echo discovered that she had a dysplastic aortic valve that was having some mild stenosis with a mean gradient of only 14 and preserved biventricular function. She was essentially asymptomatic, as you can see from this clinic photo of her. Looks like a nice, healthy, pink, chunky baby, gaining weight appropriately, no real reports of increased worker breathing, no problems feeding, no diaphoresis or color changes with feeding, and had normal EKGs in outpatient clinic. She was followed closely and was seen in the outpatient cardiology clinic about 2 weeks prior to the event, which unfortunately her echo showed some new findings, including she had some new echo brightness of her anterolateral chordae and papillary muscles, as you can see on this echo picture. I don't think my arrow is showing up. There it is. So you could see there the papillary muscles are pretty echo bright. And she also had a new finding of worsening mitral valve regurgitation as seen here. Despite these new findings, she was still relatively asymptomatic, although parents did report that she was a little bit more fussy than usual. So cardiology had some discussions about how to best proceed, cath versus CTA, to evaluate her coronary anatomy given the echo changes. And it was, she was also started on some low-dose captopril given her MR. In the end, it was decided to pursue a CTA of her chest to evaluate the coronaries and to rule out things like L-kappa. So she was ordered this outpatient CTA, and unfortunately, when she was undergoing the induction for anesthesia, she suffered a cardiac arrest, which was described as ventricular fibrillation. This was, like I said, occurred in the outpatient CT scan. CPR was initiated by the anesthesia team, and multiple defibrillation attempts were made, but were ultimately unsuccessful. So this prompted a CICU arrest page to be activated by the cardiac anesthesia team in the CT scanner. We have a system by which these arrest pages will kind of summon all the people that need to be there in order to get a kiddo onto ECMO quickly. So it pages a surgeon, the OR team, the perfusionists, and the ICU team, including CICU attending, clinical leader, and an emergency drug cart. So as mentioned before, the location, although this wasn't the actual CT scan, it kind of looks kind of like it, although this is actually probably a bigger room than the actual CT scan that this patient was in. And so when I had arrived, it was quite chaotic with a lot of people in the room already. Active CPR was being done, and the kid had was intubated, not even had the ET tube taped yet. So we secured the airway, and kind of situationally, I deemed that it was probably not the best place for all those personnel to be. I think it was a very cramped space. And there was a small anteroom that led to the CT scan that I wasn't sure that the perfusion team could actually traverse. So we made the decision to move the patient to an ICU. Also unfortunate was that our ICU was full at the time, and so we luckily have a lot of connections. And I've done this for a while, so we made some quick calls and secured a bed in the PICU. We were able to transfer the kiddo from a CT scanner bed to a regular bed. Anesthesia secured the airway, bagged the patient while we continued high quality CPR. And we were able to move the patient from the second floor CT scan to the fifth floor PICU bed. CPR was continuous during the transport and was of good quality. So when we got to the PICU, we were met by the surgeon, Dr. Castro Medina, and we placed the kiddo onto ECMO via the right neck vessels. We initially had some troubles flowing adequately, and so CPR was continued until we were able to troubleshoot things. We noted that the venous cannula was probably on the deep side, and clinically the kiddo was kind of rapidly developing some ascites, which also led us to believe that there was a problem with the venous cannula. So the venous cannula was then repositioned, and full flows were able to be achieved on ECMO. We then defibrillated successfully and then restored sinus rhythm. So CPR was continued throughout the transfer of the patient from the CT scanner to the PICU. We already had 3 good working PIVs that we used for code meds. There was no need to place an IO. It was, I would say for our standards, it was a little bit of a longer time till we achieved full flows on ECMO, but I still think a reasonable time given the logistics of everything. So it was 60 minutes from the time of the initial arrest until the time of full flows were achieved on ECMO. The cannulas were in place probably 30 minutes into it, and it took us some time to kind of adjust things and get things in the right spot. So total downtime around 60 minutes. So post ECPR, we made a decision to go to the catheterization lab. So she went to the cath lab about 2 hours status post arrest, where they found an interesting finding, and she had not an L kappa, but she actually had some dysplastic aortic valve tissue that was obstructing the left coronary os. And as you can see from the aortic root shot here, there was really no filling of the left coronary artery. So we knew we had a problem that likely contributed to the CPR event. And so we had thoughtful discussion about when to try to address it. So we watched the kid for a couple hours. She had normal lactates, was making good urine, remained in good sinus rhythm, and actually had good pulse pressure even on full flow ECMOs. We got a head CT given the duration of the arrest just to make sure there was nothing untoward. I bring this up just because I think it was an interesting debate, and if anyone sees this in their practice, they can always kind of think about this case. But we first saw this scan, everyone was kind of freaked out and thought we had some big head bleed. But then we remembered that the kid just had a bunch of contrast during the cath procedure. And this was just the cath kind of blush in the dural venous sinus. And essentially the brain parenchyma was unremarkable. Because of that, we decided it was okay to go to the OR. She went to the OR that evening, and she had bicuspidization of the aortic valve. So they basically took down the piece of tissue that was obstructing the left coronary os. She had enlargement of the aortic root with a homograft, and she was actually able to be decannulated off of ECMO with repair of the right carotid artery and repair of the right internal jugular veins, for which we placed her on ECMO during the arrest. She actually came off with good function, lungs cleared up nicely. We decided to do therapeutic hypothermia for 24 hours. Like I mentioned before during the fireside chat, we have low threshold to add EEG. She'd have some occasional seizures, none of which were sustained, which were abated with phenobarbital and Keppra. Repeat neuroimaging otherwise remained normal. She had delayed sternal closure. Her chest stayed open for 3 days, which I don't think was unexpected. And that was a picture of her immediately post-chest closure. She was able to be extubated on post-op day 7. Residual sequelae, she had some left vocal cord paresis. And most of her time, hospital time, was working on enteral feeds, which she was able to kind of achieve on her own. And she was able to be discharged from the hospital on post-op day 30. That's her with her dad up on 7A when she was doing really well. So a few discussion points that I just thought I would kind of bring up. I think whenever discussing ECPR, we also have to remember that we still have to do the CPR portion. So, just because we have ECMO as a backup doesn't replace our need to have high quality CPR, especially if we want to have good outcomes from ECPR. It is an extraordinarily team effort, and so usually there's 3 teams working closely together, and in this case there were 4 because anesthesia was also involved from the beginning of the case. So the ICU team, we run the CPR. That includes us, the nurses, respiratory therapists. There's the surgical team who are actually performing the ECMO cannulation, and there's a lot of kind of the perfusion team also is very important in getting the ECMO circuit primed and ready. In this case, with her size, we usually would blood prime a circuit. We have circuits kind of on the standby ready that are kind of kept running with crystalloid, but in her size, the blood prime was not delayed. And so we were able to kind of do these things quickly. I also think that, it's a high stress situation. A lot of the times what we have to do as ICU docs is kind of coordinate with the surgeons who are doing kind of intricate work in order to kind of get the kid onto ECMO. And sometimes we have to actually stop CPR on their commands especially when they're placing the arterial cannula. And, we have to be really in tune as the leaders of the group, kind of coordinating with the surgeons when we can resume cannulation so we don't cause any sequela from patient movement. Lillian Sue and her colleagues at Washington at DC Children's actually published a paper analyzing the tasks that go into placing a kid on CPR. And they actually identified 90 individual tasks that need to be accomplished before a patient can be placed onto ECMO. So it is a team effort in order to get these kids on. Briefly, the location of ECPR, I would say most of the time in our hospital, we kind of go to the patient. I would say that 99% of the time, ECPR situation is going to occur in an ICU. So there really doesn't really need to be too much movement of the ICU team. But there does seem to be the occasional kid, such as this case, and a few times a year, I say that, we have a call to cannulate someone in the ER. I found a paper from some colleagues at CHOP who actually, looked at quality of intra-hospital, quality of chest compressions during intra-hospital transport, and they actually found that basically people were able to do quality CPR even while doing intra-hospital transport, and that definitely was the case with our girl. The other thing is, troubleshooting the ECMO cannulas and not being able to flow. So, we usually will do at minimum a chest X-ray, and sometimes, if this is more of a planned situation, we could have real-time echo as a guide. But we noticed fairly quickly that the venous cannula was deep on the initial chest X-ray, and that allowed us to rapidly correct and get onto full flow ECMO. And then the other thing I think that we are pretty aggressive at this institution is that we don't delay in trying to find a reason for the arrest. And then if we suspect that there's a correctable lesion, we go and try to fix it, because as I was always taught and like to teach my fellows, is that every day on ECMO is a bad day, and it is our job to try to do everything we can do to not only come off but stay off of ECMO as soon as possible. Lastly, I think that, when it comes to what we can do better, I think that, given that there's 90 individual tasks that need to happen, I think simulation plays a big part. I know that you guys are going to do some simulation later on. We also do some debriefs on all cardiac arrests, especially the ECPR cases, to try and highlight what went wrong or what went right, and if there was any areas for improvement. There was a paper also in the same paper from Lillian Sue. She showed that simulation can actually decrease the time to getting onto full flow ECMO from 51 minutes when down to 40 minutes. That was statistically significant when they implemented a pretty rigorous simulation program at their hospital. That is our girl. She is now almost 2.5 years old. She is thriving. She is in preschool, and that's her with her mom. And I think it was her outcome is definitely a culmination of the great team effort that everyone provided, not only during the event, but also her surgical course and post-op care. I think we definitely had a great outcome in this case. That's all I have. If anyone has any questions, I'll be happy to try to answer.
There were no questions, but if any did, thank you so much. Thanks, Matt. That was a great talk. We are going to go ahead and take a little bit of a break. Our next talk kind of rolls right into our simulation, and we're running a little ahead of schedule. So I don't want to move forward with that talk until we're ready for the simulation. But kind of in speaking, what you're going to see coming up here in about 30 minutes is how we're looking to try to continue to advance what we provide for our patients in the way of extracorporeal life support. We look at ourselves as the ECMO team, So ECMO, extracorporeal membrane oxygenation, but what are other ways that we can provide extracorporeal life support to patients? So that's where the Lucas device kind of comes in, and I'll speak to that when we come back right before Dr. Horvat gives his talk and before we lead into the simulation, kind of what our goals for the future are here at Children's Hospital for our ECLS program. So stay tuned, and we'll be back right around 3:20, 3:30. Okay, we're back now with the final two segments of our program. We're going to start off with a talk from Dr. Chris Horvat. Chris is the Director of Condition AC here at UPMC Children's Hospital of Pittsburgh. He's going to talk to us about mechanical chest compression devices in ECMO. So we're going to talk about use of the Lucas device. So this kind of came about for us because we saw a subset of patients here in the pediatric population that we felt could really benefit from use of the Lucas device and mechanical chest compressions. I'm going to turn things over to Chris, and then when we're done there, we'll move into our simulation.
Good afternoon, everybody. Thank you for that introduction. I think I'll start by just translating condition AC. If there's anyone following virtually who might wonder what that term is, that's our local nomenclature for our code blue and rapid response system here. So condition AC, condition A stands for arrest, and condition C is rapid response. And I have the privilege of helping to lead our rapid response systems throughout Children's Hospital of Pittsburgh. And for those of you who may be joining the conference as part of just an effort to obtain a foundation in ECMO, we'll talk a lot today about ECPR, which is extracorporeal cardiopulmonary resuscitation, or the initiation of ECMO in the setting of active CPR for cardiac arrest. ECPR is something that was first reported on in the early 90s, actually at our own institution. Dr. Neonatal and Dr. Dalton generated some of the first case reports on ECPR initiation. And what we've seen in the decades since is an increasing volume of literature surrounding this phenomenon, with relatively static survival being reported. In fact, when we looked at the early case series as collected here by the ELSO guidelines, you can see that survival in some of the initial reports was as high as 60%. As we've seen ECPR become used much more widely in a variety of scenarios and patient phenotypes, that survival now tends to hover down towards 30 to 40%, depending on the case series or cohort study that you're looking at. This is a recent systematic review and meta-analysis of the initiation of ECPR in the pediatric population. And the key takeaways here are that ECPR was used for more than 70% of children who are cannulated in the setting of primary cardiac arrest rather than respiratory. The overall survival was 46% in the systematic review, but favorable neurological outcome was about 30% of those who were recipients of ECPR. We look at outcomes for the last 3 years within the ELSO database and stratified by adult, pediatric, or neonatal. You can see the volumes here in the survival following the initiation of ECLS in the setting of ECPR. For adults, it's about 45%. For children, non-neonatal children, it's about half. And for neonates, ECPR is an impressive 65% survival in the last 3 years. At our own center, our numbers largely parallel these. We have a relatively low volume of adults, as one might expect, given that we're a children's hospital. But we've seen 26 cases of ECPR in the last 3 years, and these numbers were generated just a couple months ago in August, with 60% survival. And then in our neonatal population, we have a smaller volume of cases over the last 3 years, but still 60% survival. And then survival to discharge or transfer, I should note, is 30 to 40% between those two groups. So I wanted to start today by talking about our approach to ECPR and how we're leveraging the new technology of Lucas to optimize our delivery of CPR as we're working towards cannulating patients who are experiencing cardiac arrest at our institution. And I'll start with a very general case derived from a real example in recent months. So recently there was a young adult male with past medical history of solid organ transplant, and related to that, challenging vascular access with multiple thromboses throughout the body, who experienced, unfortunately, sudden decompensation on the ward. Our ICU team was consulted, and a decision was made to transfer. He deteriorated rapidly, and soon after arriving to the ICU, he experienced cardiac arrest in approximately 2 minutes after arriving in his room. CPR was started and he was immediately intubated. The ECMO page went out, and as Dr. Pakoris mentioned, we have a well coordinated system for initiating ECMO at all hours of the day, 7 days a week. And so the system was activated in this case. And while we were waiting for the ECMO team to arrive with their equipment and prep for cannulation, the Lucas device was obtained by one of our lead PICU nurses. And I'll show you where we keep that device in just a little while. Intermittent ROSC was obtained throughout the cardiac arrest period, and the patient developed VFib at one point requiring defibrillation. And the Lucas device was placed while our surgeons, who are very skilled at this, worked on cannulation for over 60 minutes. This was a very challenging vascular access situation. I'm going to show you a brief video about what the Lucas device looks like if you haven't seen it before. And it talks about how this device is placed on a patient who is undergoing active CPR to provide some context with respect to what this looked like in the moment while we were taking care of this particular patient.
Did you know that you can minimize hands-off chest time during Lucas chest compression system application to just 10 seconds or less? With quick and proper application, the Lucas device has been proven to increase blood flow to the brain by 60% compared to manual CPR. Let's get started. Begin high-quality manual compressions immediately after arriving on scene. As your partner is performing compressions, use ABC 123 to prepare the device for use. A stands for activate. Open the carrying case and push the green on-off button. The device is now activated and ready for application. B stands for backplate. Remove the backplate from the top of the case. Notice the suggested placement marker diagram for reference. Coordinate a natural pause in compressions with your partner and place the backplate under the patient. This will be your first hands-off moment. If coordinated well, this should only create a few seconds off the chest. Once the backplate is under the patient, your partner can immediately resume manual compressions. C stands for compressor. Lift the upper part from the case with the control panel facing toward you. Cradling the device like this allows for optimal placement control. Quickly pull and release the yellow rings to ensure the claws on both sides are open and ready to meet the backplate. As your partner continues compressions, attach the support leg nearest you to the backplate. Coordinate with your partner and swing the device quickly over the patient and listen for a click as you attach the other support leg to the opposite side. Pull up once to confirm the parts are attached on both sides. Your partner can continue manual compressions during the application. The controls on the Lucas device are labeled 1, 2, 3. First is adjust mode and indicates lowering the suction cup to the chest. When placing the suction cup, the compression point should be at the same spot as for manual CPR. Second is the pause or lock indicator. When you press this key, the height position of the suction cup is fine-tuned and locked into the start position to ensure proper compression depth. This is the second hands-off moment. If coordinated well, this should only create a few seconds off the chest. The third indicator, active, starts compressions. You have two options from this mode, 30 and 2, or continuous compressions. The three control steps allow for only a few seconds off the chest. Remember to prioritize proper placement. And that's it. I hope this tip helps make your job easier so you can focus on saving lives.
Perfect. So for those of you who haven't seen the Lucas before, I think that provides a really nice introduction to what the device looks like and how it's applied in the midst of active CPR. And I think there are a few things that are evident in that video that are worth highlighting again. One is that you saw that the compressions continued while the device was being applied. It's ergonomically designed so that it can be applied through the arms of someone while they're actively compressing. There's a brief interruption required as the backboard is placed, but then afterwards, compressions can resume until the device is really ready to be activated on its own. If you haven't seen the device before, it's fairly intuitive to operate. And the first time I actually encountered it was when it arrived from the field for a patient experiencing traumatic cardiac arrest in our trauma bay in the ED. And I'd never seen it before, but the buttons, fortunately, were fairly self-explanatory. There's a pause button, and there's two modes. There's continuous CPR for patients with an advanced airway in place, and there's 30 and 2 if you're using bag mask ventilation. And then the other thing worthy of highlight there is that once the device is applied, you can apply it over the defibrillation pads. In our institution, those are the pads that connect to a Zoll defibrillator. And while the device itself isn't meant to be used with the puck that measures compression depth, it can be used while you're actually defibrillating. So there's no reason to pause compressions for a patient in VFib or VTAC while you deliver the shock. And that's really a nice advance. There are a number of other reasons that we opted to introduce this recently into our institution for use in the setting of in-hospital cardiac arrest as a bridge to ECMO. For one, patients in cardiac arrest at our hospital can sometimes require transport in order to be taken to a setting that can accommodate the entire ECMO and perfusion team. You know, we don't just experience patients, unfortunately, who arrest in a hospital bed. These things can happen suddenly and unexpectedly while children are in playrooms or visiting in the lobby or the cafeteria. And in those situations, the perfusionist team and our surgeons require obviously a different environment in order to place the patient on ECMO. And in those cases, we have to continue chest compressions until we can get to that environment, whether it's in the emergency department, the intensive care unit, or getting the child to the OR. And so the Lucas device allows us to do that much more easily than was previously possible. We have a complex patient population here, and that complex patient population can require prolonged cardiopulmonary resuscitation. And we're an institution that has published some strong data related to the fact that not all prolonged in-hospital CPR is futile. And so we look for the devices like this that can help us bridge as a transition to ECMO to ensure that we give every child the best possible chance of meaningful survival. And then a body of evidence is indicating that consistent high-quality compressions are delivered by the Lucas device. And well, certainly we strive for that as humans. In longer code situations, it becomes increasingly difficult to maintain consistent high-quality CPR. And the Lucas obviously has advantages in that it's a machine constructed to do just that. And then that opportunity to continue compressions during defibrillation is key. And finally, it opens up the room by eliminating the need for long lines of clinicians and staff who are waiting to relieve the current compressor every 2 to 3 minutes. And so this actually frees up a lot of bed space. It frees up the bed space for our surgeons to be able to have a slightly more optimal environment to perform cannulation. It frees up the bed space so that we can work on other things like vascular access in our patients. And it just clears out the room and can help control some of the chaos as well. So there are those advantages to using the device also. Well, we saw those immediate advantages when we looked to introduce the Lucas in-house, but we also took a look at the literature as well to understand whether it's been associated with improved outcomes. There are some very practical considerations that led to our decision to bring the Lucas into our AC program and our ECPR program, but there is a body of emerging evidence of scattered quality and scattered findings that I want to walk through right now. And I credit again to Dr. Kim Campbell, who helped identify many of these papers as part of a literature review. So the first is a prospective observational study of nearly 300 out-of-hospital cardiac arrest patients in Eastern Europe and the Czech Republic, where there were 2 stations that used the Lucas device and 2 paramedic stations that perform manual CPR. In this case, they excluded children. They excluded patients who had ROSC in under 2 minutes, or if there were a contraindication to Lucas, such as patient size. And so the Lucas device was used in 144 patients, the manual CPR in 134. There was no difference in this case series of return of spontaneous circulation, but the Lucas group had more conversions from non-shockable to shockable rhythm, 20% versus 10%. The 30-day survival rate was actually lower in the Lucas group. There were no significant difference, though, in the 180-day survival, 5% in the Lucas group, 5% in the non-Lucas group, 9% in the Lucas group, and then there are clear issues with power, and this is an observational study, not an RCT. So no firm conclusions, but some initial data. There has been higher quality data, however, related to the use of the Lucas device. And this was a randomized controlled trial known as the LINK trial, Lucas and cardiac arrest. And this was conducted at 6 European centers including Swedish, British, and Dutch centers between 2008 and 2012. There was a cardiac arrest algorithm used in which the Lucas device was deployed in approximately 3 minutes with defibrillation versus manual CPR in patients experiencing out-of-hospital cardiac arrest. And they actually randomized more than 2,500 patients, 1,300 into the Lucas arm, 1,289 into the manual CPR arm. They saw no difference in outcomes. 4-hour survival was the primary outcome, and no significant difference. Also, no significant difference in good neurological outcome at ICU discharge, hospital discharge, or 1 and 6 month follow-up. There were some very meaningful sub-analyses, though, that I thought were important to bear in mind, especially since this was not a population that's immediately generalizable to the patients that we take care of at Children's. So in a subset of 206 patients from 2 sites in the LINK trial, they used electronic downloads of continuous ECG and impedance data from the defibrillators. They saw that there was high-quality CPR in both groups. The median chest compression fraction in the manual CPR group was 0.79 and slightly higher in the Lucas group at 0.84. Once the Lucas was applied, which was in 5 minutes of beginning the recorded signals, in 89% of the patients, the median chest compression fraction over the next 10 minutes was 0.91, so even a little bit higher than the manual CPR group. During the Lucas use, 70.9% of shocks were delivered without pausing compressions, with a median peri-shock pause of about 10 seconds for manual CPR. So we're seeing less interruption in CPR. We're seeing a greater chest compression fraction. So some indicators that are subtle but potentially meaningful that the Lucas device is allowing us to deliver higher quality CPR. This is another RCT of a cluster randomized pre-hospital study conducted in UK ambulance services. And the clusters consisted of ambulances randomly assigned 1 to 2 of Lucas versus manual compressions. So every 3rd ambulance carried a Lucas device. There were 4,471 patients in this study. 2,819 received manual CPR and 1,652 received the Lucas device, though only 60% actually received the Lucas device in those cases. And there were no difference in outcomes. 30-day survival was the same between both groups. Sustained ROSC occurred in the same proportion. 3 and 12-month survival was the same. And survival of the favorable neurological outcome was the same. However, you can see that adherence was not according to the a priori power calculations, with only 60% adherent to the Lucas protocol or requiring the Lucas as part of resuscitation. If we turn our attention from out-of-hospital cardiac arrest to the in-hospital setting, which is how we're using the Lucas now at Children's Hospital, we take a look at some of the data out of the University of Chicago, which conducted a retrospective study between 2011 and 2016. And they looked at in-hospital cardiac arrests, and they deployed the Lucas into their environment in 2014. Identified 43 patients requiring chest compressions while in their cath lab. 12 received manual compressions, and 31 received the mechanical chest compressions. Patients receiving mechanical compressions were more likely to achieve ROSC, and this is a pretty striking difference in proportion, 74% versus 42%. 71% of those receiving mechanical compressions were also treated with mechanical circulatory support, with 100% achieving ROSC. There were no episodes of limb loss or major bleeding. And 75% receiving manual compressions were also treated with mechanical circulatory support, but the outcome data were not presented in this manuscript. There is no difference in 30-day survival or survival of discharge. Again, it's an adult institution with arrests occurring in the cath lab. Some a little bit more in-hospital data. So this was 28 in-hospital patients in the late 2000s from Germany and Sweden with pulseless electrical activity. The majority of these patients had a pulmonary embolism, 14 of them, 9 with cardiogenic shock, 2 with hyperkalemia, and 3 with a sustained arrhythmia. And during or after CPR, 21 underwent coronary or pulmonary angiography, followed by PCI and thrombolysis when indicated. And ROSC was achieved in 27 of these 28, with 14 patients surviving to discharge. 6 patients with a P had contraindications and did not have thrombolytic therapy. And notably, CT angiography showed fragmentation of the thrombus, suggesting thrombus breakdown as an additional effect of mechanical chest compressions. And what I didn't mention earlier about the case in which we deployed the Lucas is that we learned later that that patient had suffered a pulmonary embolism. And when he was taken to cath lab, there were multiple fragments of that embolism found scattered throughout the lung. And the hypothesis there was that the Lucas high-quality CPR probably contributed to some fragmentation of the thrombus. This type of observation is reported in other case reports. The first case report here is a pre-hospital report of a 54-year-old woman with chest pain and dyspnea who went into PEA and as a result of a massive pulmonary embolism. And she received pre-hospital thrombolysis, and then the Lucas device was actually initiated. Received 75 minutes of effective chest compressions before ROSC was obtained, and the patient regained consciousness the next day in the ICU, and 3 weeks later was sent home in good neurological condition. And the authors here, again, these are adult intensivists and clinicians who take care of adults with cardiac arrest fairly routinely, discussed that they thought the prolonged CPR may have contributed to mechanical fragmentation of the pulmonary emboli, enhancing the effect of the thrombolysis. And then the second case report had similar conclusions. This was the use of a Lucas device as treatment of a valve thrombosis in a patient in cardiac arrest. And again, the author speculated that the combination of the Lucas CPR, which provides consistent, high-quality CPR with an appropriate depth of compressions, may have hastened the valve mobility and reduced the arrest time. There is some operator dependence to the Lucas device that's been reported in the literature that should be mentioned, and I think accentuates the relevance of the simulation that we'll see in just a little bit here. So one case report is of a 65-year-old male in cardiac arrest after septic shock. The Lucas device was applied. The depth was actually measured of the chest compressions with the accelerometer attached to the Zoll. The end tidal and systolic blood pressure were considered suboptimal with the Lucas device, and so manual compressions were instead started, and they thought to achieve deeper compressions with a better end tidal reading and a better systolic blood pressure. Although the details of what may have been incorrect about the placement of the device aren't presented here. And then a 19-year-old male collapsed while exercising. Bystander and paramedic CPR was initiated without ROSC. The patient was taken to the ER with manual compressions ongoing, and the Lucas was applied. The end tidal was undetectable despite replacement of the endotracheal tube. Switched to manual compressions to achieve deeper compressions, and then the end tidal became detectable. And so there was some question in both of these cases about whether the operators had insufficient training and knowledge in resuscitation, and whether the Lucas device was being appropriately used in those hands. Finally, a prospective Denmark study in 2011 and 2013 in 696 non-traumatic out-of-hospital cardiac arrest patients. 155 were treated with the Lucas after manual CPR. Quality was evaluated using transthoracic impedance measurements from the LifePak 12 defibrillator. And you can see here that there was a significant difference in the duration. So those who received the Lucas had a longer duration of CPR, but had a lower no-flow fraction with the Lucas device in place compared to manual CPR. And the chest compression rate per minute was right at 102, I should say, per the recommendations of the guideline. And I'll offer that this is what we observed as well when we used the Lucas for a recent ECPR case, is that we had great perfusion tracing on the monitor. Stats were 99%, and the heart rate was consistently 101 to 102. And then the number of chest compressions per minute, the manual CPR was 75 versus 84. A little bit more look at safety of the Lucas device. There was a Dutch randomized non-inferiority safety study looking at the Lucas versus another automatic compression device called the AutoPulse versus manual CPR. There was no difference in outcome between the Lucas and manual CPR in the primary outcome, which was serious or life-threatening visceral resuscitation-related damage, as evident by clinical course or post-mortem CT scan or autopsy. So 7.4% sustained resuscitation-related damage in the Lucas group versus 6.4% in manual CPR, and that was higher in the AutoPulse group. And there was no difference in the secondary outcome of severe rib fractures or sternum fractures, with 39.8% in the Lucas group, which is actually the lowest out of all three arms, and 41.3% in the manual CPR group. And you can see that the breakdown of those here, that the highest rate of pneumothorax in the AutoPulse, the lowest actually in the Lucas group, and relatively small counts overall for serious or life-threatening resuscitation-related injury. Similarly, related to rib fractures, a Swiss retrospective study analyzing consecutive autopsy reports after unsuccessful CPR contained 26 patients who received the Lucas device and 32 received manual compressions. The duration of CPR in the Lucas patients was longer, with a mean of 51 minutes versus 29 minutes in the manual compression group. And you can see here that there were more cutaneous anterior lesions observed in the patients who received Lucas, and more rib fractures as well, more than twice as many rib fractures. And that increase in rib fractures was true even if they restricted it to the patients who were received less than 60 minutes of CPR. So in summary, Lucas device at the very least can be deemed not worse than manual CPR, and there's some indications in the literature and secondary analyses that the CPR quality is actually higher. But there is the important caveat that there is some operator dependence for this, and it needs to be applied correctly. It is intuitive, and it's fairly straightforward, especially once you've been able to handle it at least once. But given the stress associated with these types of scenarios, it's best that the team be trained appropriately before they encounter a real patient in need of the device. It's helpful also to clear the field and to time compressions in the setting of ECPR. It gives our surgeons room to operate, allows our intensivists to be working on things like vascular access, and can help reduce the chaos in these types of scenarios. But there is this possibility that's conferring some additional risk of injury as a result of the delivery of consistently high quality CPR. So we've opted to introduce it into our program, recognizing its pragmatic utility, and like anything else, as part of the consistent theme of the day, I think that there's the ongoing need for individualization in terms of who we're selecting for the Lucas. Our institutional policy is that we use it for patients who weigh greater than 45 kilos. The manufacturer recommendation is that the chest should be about 6 inches in diameter, and that's about the length of my hand as a quick measure in these types of situations. And here's where we keep it. We keep it charged next to what we call our super carts. And these are the crash carts that we take to all of our resuscitations in-house. Conveniently, the Lucas can be transported in a backpack. And so this is available to all the ICUs in-house, any inpatient arrest in-house. And if the emergency department were to need it, they know that it's available and they can come up and obtain it here. Perhaps the final thing to mention is that it is battery powered, but if it's going to be used for an extended period of time, the manufacturer and our team knows to, has recommended, and our team knows to plug it in to ensure that its compressions are not interrupted. So with that, I have to say I'm honored to have had the opportunity to tell you a little bit about this program that we've been rolling out. I think that we have a really exciting simulation scenario next up. Maybe a couple of minutes for questions I'd be happy to entertain if there are any. Otherwise, I will turn it over to the next and final component of the conference today. So thank you very much.
The only question that came in was about my title, but then you addressed it. Okay, thanks. Great. Thank you, Dr. Horvat. Okay, we're going to go ahead and move on into the simulation. Like Chris talked about, and like I mentioned earlier, we have decided to try to implement the Lucas into our ECLS program here. And while we're the ECMO team, we really saw a subset of patients that could benefit from the use of the Lucas device. We're treating patients. Patients are living longer, so we're treating our congenital patients into adulthood. So we have a lot of adult-sized patients, and like Tim talked about on the first day, kind of the coming of age talk is, when do you treat pediatrics like adults? So we do have pediatric patients that are in fact adult-sized patients. So the Lucas comes in very handy for some of those patients. So that was kind of our idea behind it, is can we provide other types of extracorporeal support other than ECMO to our patients? So we're going to go ahead and get started and switch over to our simulation here. So we're live with our simulation now. You can see we have the patient on the stretcher. We're going to have kind of just start mock code, show how the Lucas device is placed on the patient, and Chris and I are going to kind of narrate and give any other information we think is pertinent during the scenario. So we have a patient that has arrested, getting active CPR. We call for the Lucas device. Like Chris said, we keep it in the code closet. Right now we have our PICU clinical leaders and our ECMO team that know where the device is. They'll go and retrieve it, and they bring the device in so that we can go ahead and get that on an appropriately sized patient. We've developed our own guideline here for use of the device. We use the backplate for the Lucas that is radio peg, so you can x-ray right through it. We time everything that we do with a pulse check, so we're not really interrupting CPR while we're getting the device on. You can see here Sam powered it up before she got out of the backpack. She put the backplate on. She's able to weave the device through Sean's arms while he's still doing CPR. So again, she'll get that ready to go. When it's time for another pulse check, we'll check the pulse. We know we need to keep going with CPR. We can hit the buttons and the Lucas device will kick in. Now at this point, it's nice because like we said, we can get rid of that line of people that's waiting to do CPR. We've decided to call for ECMO. So our ECMO team arrives at the bedside, ready to cannulate. It's nice for them because it does get people out of the way from around the bedside so that they can have the most amount of room to work. It also limits the variability in the quality of compressions that the patient is getting. With the Lucas device, we know what we're getting, we know the depth, we know the rate, and the patient is getting good quality CPR throughout the event. We're going to look to do a percutaneous femoral cannulation on this patient. So we have the point of care ultrasound ready to go. Dr. Villegas and Dr. De Fonseca de Silva are going to run the ultrasound device so that they can use the images to do a percutaneous cannulation.
The other thing to highlight is that you can see the entire left side of the bed is occupied by the surgical team, the OR staff, and by using the Lucas device, the right side of the bed is still fairly open. And so our team can be working on things like arterial access or a central line in that left groin, if there's not already one in place, in order to continue the other elements of the resuscitation while we're getting the patient onto ECMO.
We have Sean ready with the lines. He has those handed up. Right now, we don't have our standard ECMO cart in here. We have a transport ECMO cart, which is equipped with one of our Thoratec pumps. We fitted the transport pack with a holder that can accommodate a Nautilus oxygenator because that's what we're currently using, along with the Centromag pump head. So you see Sean has handed up the lines. They're going to go ahead and clamp the lines and get ready to connect those to the cannulas once the cannulas are inserted. Sean and Tom both clamped the lines out. Now the lines are ready. As you can see, Dr. Villegas and Dr. De Fonseca de Silva are still working to get the cannulas in. They work in tandem. Again, I think it's important to notice here that you don't hear a lot of talking. You just see Tom Scullin, who is our scrub tech. He's one of the scrub techs in the CVOR. We talked about the importance of having a scrub tech that's in sync with your surgeons, knowing what they need before they know that they need it. Emily did a beautiful job on Monday showing us how she worked alongside Dr. Villegas, again with minimal talking and minimal disruptions and just knowing what she needed to give them when she gave it to them. Tom is doing the same thing. We're very fortunate here that we have such a competent scrub team here for our cardiac surgeons. So now we're working to get the cannula down that guide wire. So we're going to do serial dilation. And then here we see the cannula going in. You can again hear the Lucas device continuing to thump in the background. We don't have to pause for a pulse check unless we see a change in the rhythm and we want to go ahead and get a look and see if we have achieved ROSC. You can see how it really does provide extra space for the surgeons and for the scrub technicians to work and be able to really get around the patient and get to where they need to be without being obstructed by anybody that's providing CPR at the head.
Yeah, it's a good demonstration where these days we have a Lucas device in place. If we have a well-placed endotracheal tube, we even place the patient on the ventilator. And it's removing even more people who may not need to be in the room, out of the room, and creating more space for people to work and do the things that they need to do in these scenarios.
This simulation model that we're using here is really nice because you can ultrasound it so that you can see the vessels that have been embedded into the ballistic gel. So it just improves on the high fidelity that we're trying to offer for our simulation offerings here at Children's Hospital of Pittsburgh. So again, we're just feeding the cannula down the guide wire. Intravenous cannula going in. We're going to go ahead and connect the lines to the cannulas. And then as soon as we get our clamps popped off, we're ready to go on ECMO. And you hear Sean verbalizing that he's going on ECMO. He's going to come up on his flow and let everybody know how things are going. At this point, if we've achieved the flow that we want to achieve, we can go ahead and, in fact, stop the Lucas device because we're now on VA ECMO, so we can hold the compressions. It's important to note that the Lucas, when you shut it off or pause it, does not keep itself in a compressed position. It will, in fact, retract when you hit the button. So that's the demonstration that we had planned for everybody today to just kind of again show the way that we can implement the Lucas device into our ECMO program here when we're doing an ECMO cannulation, whether we're called to the PICU for a rapid response, if we're called to any of the floors, if we're called to the ER, the cath lab, IR, anywhere, if it's an appropriately sized patient, we can grab the Lucas device and we can go. The guideline that we designed here, we tried to come up with some little cheat sheets for it. So Chris mentioned that the chest height has to be roughly around 6 inches. So we tried to figure out what was a quick way to figure out what 6 inches was. So we scoured the hospital. We found a bunch of different things that we could try and see if it would work. So what we came up with was a 60 cc syringe. So a 60 cc syringe seemed to be the exact height that we needed to decide whether or not we were going to attempt to use the Lucas on a patient. So we keep a 60 cc syringe in the Lucas backpack so that we can set that down next to the patient's chest. And if the chest height clears that syringe, we know we're good to go with trying to use the Lucas. There haven't seemed to be any questions that have come in the chat. I think this is a really great thing to add to our ECMO program, as well as really any other programs that are out there looking to move into the future with their current ECLS programs. This is everything that we had planned for this year's conference. We thank everybody for tuning in. We're very thankful that everybody joined in the conference this year. We're happy with all of the speakers that so graciously agreed to give us their time to speak to everybody that has attended. And I will again send out that email with all the instructions on claiming conference credits. And just a couple other quick thank yous to Massive Media, who was the team that came and allowed us to be able to Zoom this to all of you that are watching. Devin Corboy, who is one of our ECMO specialist extraordinaires that also doubles as a videographer. He owns his own video production company, so that allows us to be able to provide this for everybody. Dr. Villegas, Dr. De Fonseca de Silva, everybody on the ECMO team that helped participate in this program, David Palmer for creating our simulation models, and just everybody that really helped us bring this together. So thank you all for tuning in, and hopefully we'll see everybody next year.